Good evening. Welcome all to the series 2 elusive endometriosis endoscopy for all, endoscopy for every gynecologist. And today, Maharashtra chapter of IAG, that is Indian Association of Gynecological Endoscopists, has come together with the State Association of Gujarat Obstetrician and Gynecologic Society, and we have none other than the office bearer, Dr. Meenakshi Ben Patel. She has joined with us. And I have two lectures today, one by Dr. Prakash Trivedi sir, Dr. Sanjay Patel. This will be followed by the wonderful panel discussion on elusive endometriosis. So welcome you all. TOG webinar brought to you by Bharat Serum and Vaccines Limited on 13 September 2020. Thank you so much for joining us and having faith in us. We have with us today our guest of honor, Dr. Parmanand Keshavalal Shah, known famously as Dr. P.K. Shah. Dr. P.K. Shah is our mentor. He is my teacher, and I had the honor to be with him to work for 12 and a half years at Sion Hospital when I joined as a house surgeon, a registrar, lecturer, and an associate professor. Whatever I am today, it is because of his guidance, his teachings, his learnings, and I welcome Dr. P.K. Shah. We all know him. He is the guru of gurus. He is the father of ultrasound. He has taught more than 1,000 members in sonography in each and every nook and corner of India. He is, we all know, as a past president of MOGS, FOXY, IFUMB, IAGE, and he was also the past vice president of Indian College of Medical Ultrasound. Welcome, sir.
Thank you for your kind words, Niranjan.
Yes. I would also invite now our next guest of honor, Dr. M.C. Patel. Who doesn't know Dr. M.C. Patel? M.C. Patel, sir, is our vice president of FOXY. He is a consultant obstetrician and a gynecologist, a very big leader in the medico legal department. He was also the national president of National Medicos Organization 2016-18. He is a man in white and he deals with a black coat. That is a very unusual combination. I see a doctor in black suit and black coat, but he is always dressed in white. Welcome, sir. Not to forget that he is also the joint secretary of TOG. I would request both of them, my teachers and my gurus, to please inspire and give their encouraging words for today's webinar. Dr. Parmanand Shah, sir.
Thank you for reminding my name, Niranjan. Normally nobody calls me by my name, but I'm really happy to be here on Sunday evening with you all, and with your kind words, we can have this fantastic program today, whereby we have endoscopy for all and endoscopy for all the gynecologists, series 2. And we have very renowned speakers today in the form of Dr. Prakash Trivedi and Dr. Sanjay Patel. And we have all the luminaries from Gujarat who have joined this as chairpersons or panelists. And we are going to moderate a panel on endometriosis. So I really am happy to be here with you all. And I have with me Dr. M.C. Patel, and I don't know whether Vinit Mishra and Purnima Natkarni are joining or not. But I see Dr. Sudhir Shah, Meenakshi Patel, Deepak Bagde, and Neeraj Jadhav, who are going to chair the sessions of today's webinar. I wish you all the very best, and I'm sure I wish you success for all the endeavors that you take over in future. All the best.
Thank you, sir. Dr. M.C. Patel, sir. Thank you so much.
Thank you, Niranjan, for inviting me as a guest of honor with good friend Dr. PK Shah, and very nicely designed program of endoscopy and related to very important topic as for myomectomy, and very legend speaker Dr. Prakash Trivedi, our own, uh, our one more Guju, and nicely enjoying good position in endoscopy field at Mumbai and all over India. So he is master of the subject. So I am quite hopeful that he will be dealing with the subject at par. One more speaker you have chosen, Dr. Sanjay Patel. Very recently, he introduced butterfly approach in deep-seated endometriosis in rectovaginal area and in rectum rather. So he is also one more master in respective subject. And as far as panel is concerned for endometriosis, which is very complex subject, and still it is nightmare for so many of gynecology. If I can say in Gujarati, સ્કૂલમાં એક અળવિતરું છોકરું હોય ને એ બધા માસ્તરને પણ હેરાન કરે. એમ એન્ડોમેટ્રિયોસિસ છે ને એ પેશન્ટને તો હેરાન કરે જ કરે, પણ ડોક્ટરને પણ હેરાન કરે. એટલે અળવિતરું છોકરું છે એન્ડોમેટ્રિયોસિસ. So, but we have very legend faculties in field of this endoscopy and endometriosis to deal with. So, I am quite hopeful all the listeners, all the viewers will be benefited with the deliberation of all the panelists and all the speakers, and of course moderator Niranjan. So again, I congratulate Dr. Niranjan for keeping this good subject and keeping all the delegates to be in touch in era of this COVID-19 through web. So looking forward to successful one more webinar. Thank you very much. Yes, Vinit has also joined, and he is also one of the guest of honor with us, me and Dr. PK Shah. Sanjay has also joined. I just told something about Sanjay. He is doing marvelous surgery as far as endoscopy is concerned. So, welcome you all, and all the best for success of this webinar. Over to you, Niranjan.
Thank you, sir, for your wonderful word, inspiring word. Today we are in the land of Gujarat. Gujarat, as we know, is a land which is not only for the sweet language, but the way they talk. And I would like to tell that my whole when I was small boy, my whole vacations every year has gone in Vadodara. So I used to go to my uncle at Sayajirao University, Vikram Bagh, and I used to go to Kamati Bagh and Suisagar. And later on, I was also, the schooling was in Hansraj Morarji Public School. And I was so fortunate enough that my teacher was Dr. PK Shah. And when I was with him for more than 2.5 decades, along with him seeing patients, I learned Gujarati, and luckily I could speak and I could also converse. And that is what is the wonderful place, the land of Gujarat, very sweet language. અને તમારો ઢોકલા, દાળ ઢોકલા, પાત્રા, and all the beautiful places which I have seen. Fafda. Fafda's rus cannot be forgotten. So I am really very lucky that every year rather than once, but I am called 3 to 4 times. And this is an opportunity I thought I should come and get everyone together. And I would like now to welcome Dr. Vinit sir. Vinit sir, as you know, he is the Foxy Vice President. He is the Director of the Indian Institute of Renal Disorder Center, and we know that he is also currently the President of South Asian Federation of Urogynecology. Dr. Vinit, I request you to unmute your mic and please inspire your words for this webinar today, which is endoscopy for all, endoscopy for every gynecologist. And we love your hospitality, which you have been doing every year with urogynecology 2015, 2013, 2016, and 17. The mic is yours, sir.
Thank you, Niranjan. I have always called Niranjan as Anuj because he has always inspired me as my younger brother.
Thank you.
Friend, Gujarat is, we are in Gujarat since 56 before I was born. And all my bringing up, everything is from Gujarat. And now I had the institute called Kidney Institute. And see, endoscopy, when me, Sanjay, everybody, endoscopy somehow or the other evolved at its maximum in Gujarat and in South and in Mumbai. That was the reason why how the endoscopy kept on evolving. And all these centers, they became the mentors for the younger generation, especially when it comes to Sanjay. And Sanjay would have trained almost a huge quantum. If he puts in all the students, I don't think so anybody would, if he stands as a foxy president, no one would at least dare to stand against him because he has so many students. Out of 40,000, at least 10,000 are a very Sanjay. I'm not able to see him. But Sanjay is such a huge, he is mota in both Hindi, Gujarati, Marathi, whatever you call, he's big. He's big, he's fat, he's enthusiastic. And Niranjan, he has brought in endoscopy to its real international standard. So when everybody talks about endoscopy, and initially they were all looking towards West about endoscopy, now with the endoscopy that is there in Gujarat, in Mumbai, in Maharashtra, in South, the Westerners have to look towards us for training. And probably we are one of the best endoscopic surgeons. And we are one of the best robotic surgeons. So this is the initiative which Anuj you have taken up along with SOGOG. SOGOG is an enthusiastic organization and you have been able to bring everyone together and you are hosting this. Let me tell you, I had a viral fever. At present, I am admitted. I'm in my own institute, but fortunately, everything has turned out to be negative excepting chikungunya.
Oh.
Yes. So, all the best. And it is going to be feast. Niranjan, you are a great person. Anuj.
Thank you, sir. Thank you for those kind words. I am really impressed with the dedication this man has got. This man doesn't have time to sleep. I want to tell the rest of the whole world and India that Dr. Vinit Mishra is tirelessly doing the COVID work and in close contact with the central government, with our Prime Minister, with the State Chief Minister, with the whole administrative and the health department of Gujarat. And he has done a lot of work. I can say more than 1,500 patients of COVID, not only in pregnancy, but in all the parameters in his institute. He being the director has managed. And it is a very big efforts which you have done, sir. And I wish you a very early, speedy recovery. And I'm really impressed the way you have come today. And that is how the dedication we see. This inspires us, the younger generation. It inspires us. And I want to say, yes, sir.
Before Vinit is leave, I think we tell you, every we are in the quarantine phase at that
Yes.
time, from the 1st of April onwards.
Yes.
And at that time, Vinit is doing the day and night work. I am the eyewitness behind this one. And every day he meeting with the Ministry of the Health and everybody. And he leave the hospital sometime after 2 days, sometime after 3 days. I think he work hard and he deserve for the one of the best award what the Foxys provide for his noble work toward the society. I think we pray to the God for the speedy recovery from chikungunya. And I think all the best, Vinit. And early as possible you came out from this particularly from the this chikungunya. And I think take care related to this part, because I also suffering from the chikungunya. This is the much more painful than the corona, because it's created a lot of problem related to joint, and body is like the I think 100 times much more problematic than the corona. And please take care related to this part. Even though you take some physiotherapy, because I took the 6 month physiotherapy to came out from the chikungunya. And that's why I'm telling you, better you start as soon as possible physiotherapy. Otherwise, this joint problem still may be persistent for the longer time.
Sure. Thank you very much.
Thank you, Patel, sir.
Fully endorse word of Dr. Sanjay about Dr. Vinit. Some few days back, I called Vinit when you are free, so I can invite you for dinner at my place. And then Vinit told me, my going to hospital is very fixed, time-wise. But when I will be returned from the hospital is uncertain. Same day or next day or 2 days after. So he is doing marvelous work in his institution, and not only for this COVID era only and for COVID patients, but for other patients also. When COVID was not there, then also Vinit is doing very wonderful work, and in very rural area of Gujarat, he has taken up so many projects, say for anemia if we can say, or endoscopy and sonography in very remote places of Gujarat, he has taken up with government of Gujarat, and in almost all district places, and now he is approaching to taluka places for dialysis center, and which is great work he is doing. So each and every patient of renal failure will be able to reach to their taluka place or district place only for their dialysis treatment, and this is great work Dr. Vinit has done. So I would like to put it on record. So a good round of applause rather to Dr. Vinit for doing this noble work for the society.
Thank you.
Yes,
Now I
This is
would,
the proud for us.
Yes, it
I
is
think
proud for
Vinit
us.
is the one of the we are the friend of Vinit.
Bilkul. It is
thank
proud
you,
matter
thank
for
you,
us.
and we would like to thank.
He is doing a marvelous job. Yes.
Thank you, sir. We are in the land of Gujarat, and I would also like to thank his better half, Dr. Neeta Agarwal, madam, to take care of him. Now I welcome the TOG president to give her welcome address. Dr. Meenakshi Patel is the director and consultant of Sunshine Global and Baroda Hospital. She is the president of SOGOG. She has been practicing gynecologist since November 1990 and has an experience of 29 years. She also runs the Foxy Recognized Laparoscopy and Hysteroscopy Center. So, madam, I request you to please speak 2 lines. Welcome, madam. Unmute.
Hello, am I audible?
Yes, madam. Yes.
Okay. Thank you, Dr. Niranjan, for your kind words. On behalf of SOGO, as a president, it gives me immense pleasure to welcome to our guest of honor, Dr. P.K. Shah, sir, past president of Foxy, IAGE and MOGS. Dr. M.C. Patel, honorary joint secretary of SOGO and past vice president of Foxy. Dr. Vinit Mishra, President of South Asian Federation of Urogynecology, my dear SOGO and MAGE office bearers, Dr. Dipesh Dodakia, Secretary, Dr. Hemant Bhatt, Treasurer, Dr. Prakash Patil, Chairperson of MAGE, and Dr. Niranjan Chavan, Secretary of MAGE. Today's faculty, Dr. Sanjay Patel and Dr. Prakash Trivedi, chairpersons and session experts, Dr. Sudhir Shah, Dr. Deepak Bhagde, and all the panelists, all Gujarat Society members, all Gujarat Society presidents, secretaries, and respected teachers. We all are passing through a very difficult time of COVID pandemic that has affected our lifestyle and soul, and also changed the way we conduct the academic activities. So SOGOG is organizing nowadays webinar on a digital platform. And today's webinar is on elusive endometriosis series 2. I welcome all of you to this webinar on behalf of SOGOG and MAGA. Friends, today is the time of collaborative efforts for upgrading our skills and updating our knowledge. So today, SOGOG and MAGE are coming together to bring this event, which is on a very important topic of role of laparoscopic surgeries in endometriosis and fibroid removal. I am sure stalwart speakers and domain experts like Dr. Prakash Trivedi and Dr. Sanjay Patel will enlighten us with the tips and tricks of doing these surgeries safely. We also have other faculties whose collective expertise will be very useful to all of us for the endometriosis. And now, without wasting much of time, let us move towards the academics. I hand over the further procedure to Dr. Niranjan Chauhan. And sir, thank you for giving me this opportunity, and I am happy to be a part of this webinar. Hello.
Yes, madam. Thank you. So wonderful. Welcome you are given. I would request now you to please show the slides. And I thank Dr. Hemant Bhatt, our treasurer of SOGOG, to be here and witnessing this whole program. Dr. Deepesh Dholakia, the secretary, he is the ex-assistant professor of obstetric and gynec, NHL Municipal Medical College. His field of interest is NDVH and high-risk obstetric. We all know he wonderfully organized as a chairperson of AICOG 2017, Ahmedabad, and currently the secretary of SOGOG. Welcome, sir. Now, I would like to invite and start the session 1. And we have with us none other than the Guru, the Mahaguru. He is a teacher of teachers. He was a lecturer once upon a time at Baroda Medical College, and he has his own practice in Rajkot for last 40 years. He has authored 8 books, and at present he is the national correspondence editor in the Journal of Obstetric Gynec, FOXY. He is also one of the chairman of the FOXY Media Committee, and I welcome none other than Dr. Sudhir Shah and along with him Dr. Meenakshi Ben Patel to start the first session by none other than our own Prakash Trivedi sir. Dr. Prakash Trivedi sir will be introduced by Sudhir Shah, and I hand over the mic to sir.
Thank you very much, Niranjan. To introduce Prakash Trivedi, we have been a friend since 1980. We are both from Ghatkopar, Mumbai, so we know each other since 40 years. And to introduce Prakash Trivedi to Foxian is just like to introduce Amitabh Bachchan to the public of India. He is a master of gynecological practice, infertility practice, and pioneer in the endoscopic surgery. At present, he is the president of the ISHAR. He is a past president of FOXY and past president of the IAG. He is holding and he has held many positions at many academic institutions and societies. So it is impossible to enumerate everything, but he is a gold medalist from the Bombay University, MD and pioneer in the endoscopic work. And in the endoscopic surgery is from number 1 to number 10 as Amitabh Bachchan. I request Dr. Prakash to give his expert talk on the endoscopic surgery, especially in the removal of the myoma. Thank you. Dr. Prakash.
Thank you very much. It's a pleasure and honor, and I am a perfect person because my all ancestors were from Ahmedabad. In 55, my father suddenly realized that somebody important is going to come. So he moved from Ahmedabad to Mumbai. And then I was born in 57. So I'm totally, I always call Prakash Trivedi from India because my workplace is Maharashtra, so close to me. My surname is Trivedi, so UP is close to me. Gujarat was always close to me. With PK Shah sir, then MC Patel, then Vineet, and then Sudhir Bhai, Meenakshi Ben, have giving a talk for SOGOG and MAG is always an honor. I will be sharing the tricky subject of managing difficult fibroids. Laparoscopic myomectomy I love because it keeps giving you challenge, permanently challenge. You suture, it will rupture. You morcellate, there will be sarcoma. You name anything, everything, size is a problem, then number is a problem, degeneration is a problem. So there are many issues of planning a myomectomy. From incision, location, size, number, then it is degenerated, how to have hemostasis, reconstructing the uterus by closure, and most important is retrieval of the specimen. The most important thing I always tell, surgeries are always planned in consulting room, though executed in operation theater. PK Shah and so many great sonologists are here. So most important thing is accurate mapping and know the locations of the fibroid, rather than starting a surgery and then getting confused, which will help you to decide what will be the incision, horizontal, vertical, whether it's cervical, broad ligament fibroid, one fibroid or 18 fibroid, 120 centimeter fibroid. So I think so that is very important. Now, myomectomy, I will just start. This was an hemoglobin D. And at that time, I had Aditi Singhi as my assistant. And she told Kisar, not even one drop of blood because she's hemoglobin D. And usually her hemoglobin was 7. So we started, and from 2012, we do direct uterine clipping. So we went ahead, we did uterine clipping on both sides, injected vasopressin, and then we removed the large fibroid. Fortunately, when we did the surgery, at the end of the surgery, they realized that hardly there was 1 ml of blood, apart from vasopressin, what you inject. And if you can see, the things are coming very easily and effortlessly. The interesting point is very often we feel that uterine artery ligation leads to fertility problem. This patient conceived within 3 months and had a daughter at that time, which must be now 8 years or 10 years old. Closure of uterus is very integral part, and it's very important for people to realize that World Fibroid Registry quotes that rupture after a laparoscopic myomectomy is 3 times less than cesarean section and 15 times less than a classical cesarean section. Now, this is another case. Just very recently, she came from Jaipur, from the Loda construction, and she had a large posterior fibroid. This is why I always say that the anterior-posterior diameter is equally important than horizontal diameter. And so here, my son also was surprised how it is that I'm deciding for a vertical incision. Because if you make a horizontal incision, what happens is it will spread on the sides and you inevitably go into the broad ligament or the vessels. So what you have to do is you have to make proper that what you are going to do. Once you have done that, you dissect in a proper plane. I mean, a myomectomy, I have seen many people being very rough. They are in a hurry to pluck the fibroid out. You have to remember the last dissection of the fibroid is the most important dissection. I think so Vineet will know, Sanjay will know, everybody will know. Because last dissection keeps the neurovascular plexus which is inside the fibroid, which maintains your healing. If you damage that, then growth factor reduces and your healing will be poor. So if you see here, rather than rushing and plucking, you have to follow principles of surgery doesn't change. Don't open the cavity because it is not necessary. There are few people who say I like because of a drainage. Drainage and all is just a mistake. We do unification of the uterus. So here, if you see, though ipsilateral, my suturing is going from inside out, first layer, and then it goes in a baseball fashion. Availability of V-lock, barb suture has made life easy because it is selfless, knotless, self-retaining suture. And it was originally started for plastic surgery. So that makes a simple difference when you are handling a vertical fibroid. Now, what has happened in the world is because of morcellation issue. In fact, one of these patients called me today from New Zealand. People don't do morcellation. So this was a patient who came from Melbourne, wherein being Asian, she was told that you have probably some cancer or maybe tuberculosis. And she had a nephrostomy done and both side hydroureter. So we went ahead, we saw AMH, etc. was good. And I realized that she had a 11 centimeter big fibroid, 8 centimeter fibroid, 6 centimeter fibroid. Again, if you see, you can separate it very precisely, the fibroid. So you will modify your incision depending on how it is needed. So surgical principle remain the same. Now, when this fibroid I removed, which was the 11 centimeter, the assistant in the pelvis, she told, sir, now she's pouring urine. Now, this was a big 11 centimeter fibroid. You're doing myomectomy since 1994, and most of the patient always tell, sir, you never discuss, like most of the people, kholu bhi pade, shayad open bhi karu pade. So my point is, everything is in the brain. So you don't have to think much. Understand the principle, be gentle, because I've done my wife's myomectomy, I've done my sister's, my wife's hysterectomy with fibroid and my sister's myomectomy, which incidentally was lipoma. Here we are removing the fibroid in the back and we made the mistake of first putting the 11 centimeter fibroid. Then we learned as an obstetrician molding and how women takes care of the children. So we put all the fibroids inside the back, then created the pneumoperitoneum and then morcellate. Now, from 14th May 2015, all fibroids or all uterus which needs bisection, coring or anything vaginally are all removed in back. We have 600 plus myomectomies and big uteruses which are removed, which is the largest series in the world. 500 plus I have done, maybe 100 plus Dr. Somil has done. And if you see, it's very easy procedure and we are not worried about sarcoma. Now when we remove the bag and the entire story of $1 billion is over. As she had, we had promised her that we'll put ureteric stenting. So we stented both the ureter and the nephrostomy we remembered to remove. And we also told her that since you are from Melbourne, they have best IVF units, so you really don't have to worry about fertility. Now, this is a very usual thing which I started from some doctor's day. 7 gram hemoglobin, female within 23 to 29 years. Now, that is not the IVC, that is the ureter. So that is an hydroureter. Now, if you do an open surgery in her, it is all right. But I always prefer, because this is the vasopressin which we are injecting, we prefer to do laparoscopically, because when there is recurrence, so you have opened once, say for example, she's unmarried or just newly married, then you'll open again, then you'll open how many times? So basically, difficulties are within your mind. Here it is very important to take care of the infundibulopelvic, because if you are rough at this region, it will start bleeding. So you learn the art. I always love to do difficult things because difficult thing brings the best out of you. So you have to remember nothing is really difficult or impossible. Once your brain starts believing, okay, this is not difficult. The important point is after building her up, we did remove a fibroid in a bag and the hydroureter disappeared. We stented that left ureter. Sometimes, people are worried about the number of fibroids. So we have so many multiple fibroids. Uh, I think so till 18, even if we have 18 fibroid, we can remove those fibroids in a bag. So these are multiple fibroids. So all these fibroids are put inside a bag. You will re-suture the uterus, and because we are more worried about leiomyomatosis, which you'll understand soon. So number, size, etc. doesn't make a big difference, which my friend late Dr. Rakisina always used to tell. And we were first put it into the hysteroscope into the cavity. Then both of us were the most popular person for fibroids. So basically, you have to remember that you have to be committed to improving the art. Obviously, you will have broad ligament fibroid, and I always feel in a workshop, if you get a broad ligament fibroid, you have bad luck because the art of suturing is not seen. There's nothing like true and false broad ligament fibroid, and I always feel that the ureter is lateral to the fibroid. You have to make a posterior incision because if you make an anterior incision, the posterior peritoneum will prevent drainage. The fibroid on the right side was causing back pressure. So it's right below the round ligament. So you remove this, then put it in the bag, and then you can, there's no need of suturing. And the posterior incision allows it to be a natural drainage. So you don't have any collection. So there's no need to close the posterior peritoneum. But broad ligament fibroids are easy. Your round ligament, we fixed it together because we had incised in the original part. Now, this is an interesting fibroid which I'm showing. It's a fibroid on the uterosacral. You can see why I'm showing is this diagnosis we have made prior. So ureter we have identified. So sometimes, a small fibroid in a difficult location, sometimes people manage it improperly. Suppose if I take an horizontal incision that it can go inside. So you have to deal fibroids in all locations. And any fibroid today also, after doing maybe 12,000 plus myomectomy and removing 19,000 plus fibroid, I still love because every case is a challenge and every case is interesting. So once you remove this, that dead space is, though it is big, but it does not stretch the myometrium. So there is no need of suturing that. And everything is fine, ureter is fine, far away. Check on the table rather than repent afterwards. Now, we always say that anatomical knowledge can come by cutting tissues apart, and surgical wisdom comes by putting things together. Laparoscopic myomectomy epitomizes this treatment because the art is not just to do myomectomy, it's remove the fibroid, morcellate. At Paul's conference of images in 2003, we had called Einerson, and we had this barb suture introduced. So you can do a multi-layer closure. The first layer goes as a standard suture, how we will be taking. And the second layer goes into a baseball fashion. Now, if you see over here, I don't need the assistant to do any help to me. So you start suturing, and this has, we were used to put drain. When you used to do a single layer closure, then we used to keep drain because invariably there used to be drain of around 200 ml on day one. But after multi-layer closure with barb suture, there is never a need of putting a drain because it becomes a very watertight. Now, this is the baseball technique. It's so easy. You go inside out, come back, change the direction of needle, then again go from inside out. So it makes your surgery like an art. And that is the art which everybody has to master. And Mastering an art is not an option. You have one more needle and you can use that needle also, because it is not an option, because you have to remember patient comes to you for a laparoscopic surgery, or from world over when they come for vaginal surgery, they expect nothing less than a miracle. So you cannot let them down. So that is the use of suturing. We operate at multiple places, and a surprise adenomyoma, I used to operate 35 ART specialists. So you go there, and in our place, this was one of my sisters, Bhabi, who had a localized adenomyoma with failed IVF. When you have an adenomyoma, there is a little difference of how you do suturing. You first of all will use more of Caesar to dissect, because you want to keep 0.7 centimeter of margin, so that when you remove the adenomyoma, that you can close it. So you'll close this we used to always prefer to close with one single layer of Vicryl, which can be also done. The patient conceived with IVF in the first attempt, and when they did a Caesar, I found my anterior hole was smaller than the posterior hole, because it was placenta, pancreata, increta, percreta. So I think so you have to remember that anything can take place. Now, if you are in India, we always tell that we can pull the tail of an elephant and remove from the vagina. If you are abroad, you will widen the belly button, because abroad they are not very good in vaginal removal. But when they widen the belly button, occasionally I tell, in fact, I joke to Einarson, it's so nice, you have converted the umbilicus into a vagina, because it eventually becomes that big. So the advantage of laparoscopic surgery doesn't remain, and you spill tissue because patient is in head low. So these are the methods which a lot of people have mastered, but we are showing, because the tissue leiomyomatosis is a bigger threat rather than leiomyosarcoma. Now, about in-bag morcellation, we have the largest series published. Lots of people are always worried about leiomyosarcoma. In 90s, in 2005, 2007, 2000, we have maintained that no fibroid can develop into sarcoma, which 24 years of cancer hospital study of Vienna found that 71 leiomyosarcoma never started from a fibroid. And if that people don't believe, Novak's current textbook clearly mentioned that fibroid and sarcoma, one is gene expression and one is gene suppression. So both cannot exist. So fibroid cannot become leiomyosarcoma. If you have a fibroid accidentally when there is a leiomyosarcoma, and I discussed this with Sailesh, Sanjay, Deepak, so many other and many people, the number of sarcomas are so rare, and it can occur even after a TLH with BSO from a muscle of a vessel. So imaginary worry of sarcoma, it is not needed. Now, sometimes you have to realize that, as I told you, every case is a challenge. Here, this is a large fibroid. I will take you to straight away the interesting part. We remove the fibroid. Now we are morcellating in the bag. Now you remember that you would do naked morcellation in such cases. See the type of tissue, what it is. All this will spill into the peritoneal cavity. In fact, instead of morcellation, we had to resort to taking an ovum forceps. And finally, we took a MTP suction cannula of the biggest size and we sucked it out. So remember, bag is a solution to many issues. Learn it, and there are many people who can teach it. But you can see the type of material which is there. Now, this is an interesting case. And today is Dr. Kumar's birthday, 13th April. So I was doing a live workshop there, and in the morning, somebody opened a case which was 20 times less difficult than 20% less difficult. So I went there and he told me there is either some adnexal mass and this and that, and I have this entire case properly reported. So if you see now, once I've done, and then suddenly everybody in the audience is very keenly watching, because most of the time they know, and I think so Sandeep Patil was assisting me. If you see, it is only vessels. vessels in jelly-like material. So there is no scope of using myoma screw or no scope of using tenaculum. So we were using, if you see, the atraumatic grasper. So we dissected this fibroid, and once we dissected this fibroid, we thought that the anterior fibroid may be much more, maybe not the same like this. And then we went ahead with the anterior fibroid. So this fibroid was dissected. Obviously, the area of defect will be closed. We went ahead, and then we went for the anterior fibroid. So when we went for the anterior fibroid, we realized the anterior fibroid also, this is the anterior fibroid, was again degenerated, blood vessels all around. So we went ahead, we dissected that. So that fibroid also, the suturing was done. We will not show the suturing because, but now you see, when you put this inside a bag, you can't say whether it is a dermoid, whether this is sarcoma, what it is. And it actually turned out to be angiolipoma, which is a rare fibroid which is seen. And the beauty about this patient is, every time I was telling Kumar, send me the details of CT and MRI. So he told me, what happened was, within 2-3 months after your surgery, she is pregnant. So she's already now 7 months. Now we got all the details about this. And this is in one of the rare case report which is going on. So again, in such situation, coming to practically the last important thing, don't bother about leiomyosarcoma. This is a patient who had a hysterectomy done by a good person who morcellated, etc., etc. And uterus was removed. And now when we go back again, you see what it is there. There's one fibroid there, one fibroid here. There are leiomyomatosis, multiple fibroids which are present in different areas. So we went ahead, we removed, and sometimes the lower one you feel, this is a small one, the lower one you feel that it is probably the uterus, but it is not the uterus, it is another fibroids. So this one had 5-6 fibroids. So we removed all the fibroids. Obviously we put it inside a bag and we morcellated in a bag. Patient is doing absolutely fine. And now this is looking like a uterus, is also a big fibroid. So we went ahead and we dissected the right ureter. You have to be careful in all such situations. Finally, you have to remember, there's nothing in incision, there's nothing difficult in location, nothing difficult in size, number. Degeneration, hemostasis, suturing, closing, retrieval, there's nothing there. The most important thing, your two hands work when your brain is clear. So all the difficulties are in the mind. So the biggest difficulty lies here. So no matter what the difficulties are, make your hands work better, brains think faster, one will conquer all the problem. And in current COVID times, we have operated 50 patients with a new innovative technique. On 26th and 4th, 26th, we have a big event on innovations. We are going to declare that for everybody's benefit. And you'll realize how you can do laparoscopic surgery during COVID time. Finally, all of you stay safe, stay content, stay home, serve by telemedicines and women's health. And one of my greatest friend, Vinit Mishra, lions को छोटी बीमारी नहीं होती, chicken को नहीं हो जाता है. So please take care. Niranjan, you are a fantastic person. We wish you all the best for the upcoming election of treasurer, and you totally deserve it. Thank you very much.
Thank you, sir. Thank you so much. And wonderful presentation you have done. Dr. Sudhir, Meenakshi Ben, you have few questions. Please go ahead.
I think so, Niranjan, if you have time, then we will keep questions. Otherwise, even Sanjay's talk we can start.
Yes, sir.
Or I think so, Manish is raising his hand.
Yes, sir.
Thank you, sir, for wonderful presentation. After listening Prakash Trivedi, we don't have any words or don't have to say anything or any conclusion regarding the mastering the laparoscopic myomectomy.
Manish, you are asking
Yes,
something?
yes. Nahi, Mota bhai, it was a fantastic presentation. Very nice to see.
It's always our pleasure, and we are happy. Me, Sanjay, all brothers, and आमचे महाराष्ट्राचे आणि आपला गुजरात नवत आहे. So this is the most amazing webinar to really
Yes,
have.
yes, sir. Yes, sir. Yes.
Not to 26th Saturday before the Foxy, there is innovation. There is a very big path-breaking webinar. None of you miss it.
Yes, sir.
Including
Yes, sir.
Niranjan, in spite of your elections.
Sir, we have one question. Dr. Vanashri Doifode. Multiple myomas are to be removed by single uterine incision or whether it needs multiple incision? Please guide.
Yeah, very, very good question. Usually what you have to do is, it's a very appropriate question. When we have 11, 12 fibroids, so we inject vasopressin only in 4 fibroids. We make the best incision for each fibroid. Then if you go ahead with the remaining fibroid, that open area keeps bleeding. So we suture that and then inject vasopressin in the remaining fibroid. So you don't have to worry about vasopressin because, and in such cases, Sanjay is also aware that if you do uterine artery ligation, nothing happens to AMH and the patient has less recurrence of fibroid. So separate incision, no hood, etc., etc. But first 4 fibroid, then so by that time the previous vasopressin effect is gone, and then you can do other removal and then the suturing of that.
Thank you, sir. Now I call upon, thank you, sir, for being there. You have been so kind and generous in spite of your busy schedule. You have given your opportunity and time. And I want to tell here everyone, I was registrar under Dr. Prakash Trivedi in 1992. And it was a wonderful time, that time in Rajawadi Hospital, where I got to see open surgeries being done by Dr. Shashank Shah, and Dr. Prakash Trivedi had just got his unit. If I'm not mistaken, Dr. D.K. Tank had left Rajawadi, and that is a time when we had a lot of hysteroscopies and laparoscopies done. And I remember sir used to come even in the evening round, and he used to advise me to get sodium and potassium done, because that time we were just started hysteroscopy, and because of fluid overload or to be much more careful, I used to send all those investigation immediately post-operatively, and used to inform and call sir. In those days there was no mobile, there were only pagers, and I used to call upon the landline. So that is how our days were there. And sir, from those days of Nair Hospital, you being an honorary, and at Ghatkopar your own total health hospital, I have learned a lot from you, sir, as a registrar. And then I had the opportunity to be the registrar of Dr. P.K. Shah, sir, my mentor. Sir, thank you so much for being there. I am honored and blessed that I could get that opportunity to learn endoscopy nuances. And I want to tell one more thing, sir, before you leave. Dr. Paramananda Shah, that time Dr. Khandwala, sir, was the president of IAG, and I was sir's registrar after finishing Rajawadi. I will just take 1 minute, sir, because the younger generation don't know what happened 30 years back. That is what I want to tell you. And that time we had ordered glycine, sir. If I am right, sir, 2 liters of glycine we had ordered 1 day before, and Dr. Wamstaker had come from Netherlands, and there was one more guy who had come from UK, and wonderful display of all the surgeries 30 years back. Dr. Nargesh Mota Shah had come, and we had also seen Dr. Rishikesh Pai showing that transcervical retrograde catheterization. And sir, you were that time the organizing secretary, and I had that opportunity to see live first time after working with Dr. Prakash Trivedi in Sion Hospital. Sir, your words on that, then I will move to Dr. Sanjay Patel.
Professor Gordon Phillips.
Yes.
Gordon Phillips.
First hands-on and hysteroscopy workshop in 1993 was in Rajawadi. And what you're referring to was in 1995 with Khandwala sir, and it was in Nanavati, if I remember, hysteroscopy. That was a World Congress. So you're
Yes.
absolutely accurate. I think so you can move with the next big speaker, big in all form. Thank you, Niranjan.
So I just thought I should just share those memories which I had with both of you. Thank you so much. And it was inspiring to see those endoscopists in those days. Thank you, sir. I request Dr. Parmanand Shah, sir, to please be there. Thank you, Dr. Trivedi, sir. Now I call upon Dr. Neeraj Jadhav, our chairperson, and Dr. Deepak Bagde to be there. And Dr. Deepak Bagde, we know he is the immediate past president of SOGOG, a nice gentleman from Jamnagar. He is also the head department of Gynae, MP Shah Medical College, and he is a scientific committee chairman of Gujarat State, President Jamnagar Gynec Society. Dr. Deepak Bagde had to leave because of a social commitment. Sir, thank you so much. You are the most important person where I first spoke to you, and that's how we spoke about 2.5 months back, and that's how today we see Sogog being there with us in those tumultuous and perilous times of Corona. And I would like also now to thank you so much. I would like to invite Dr. Neeraj Jadhav. We know he's a man of Rajkot. I got that opportunity. He has invited me 4 times where I met Dr. Sudhir Shah sir and Neeraj Jadhav. A very gentleman, thorough. He has organized Yuva Foxy. He has organized the annual conferences of Rajkot when he was the president of chair and president of Rajkot Society. He is presently the Sexual Medicine Committee chairperson. My dear friend, he is also a faculty and at the state and national conferences in Foxy. A thorough gentleman. Welcome, sir, for to be with us. Now I request you to please introduce our next speaker. Thank you so much.
Thank you, Niranjan. It's my pleasure to introduce our next speaker, Dr. Sanjay Patel. He will talk on the bowel involvement in endometriosis, rectovaginal plate. And to introduce Dr. Sanjay Patel, I don't think he needs any introduction, but still I will complete the formality. He is India's pioneer person in gynec endoscopic surgery. He is director of Mayflower Women's Hospital, first gynecologist in Asia to perform laparoscopic vaginal hysterectomy in 1997-98. He is ex-course director of Asia Pacific Association of Gynec Endoscopy. He was invited as a faculty in American Association of Gynec Laparoscopy. He is best gynecologist of Gujarat in 2003 and 2019 by Indian Medical Association. He is senior Corion Awards in Foxy annual event at Bangalore in 2019. He received Foxy Corion Award 2007 for research work in salpingectoscopy. He has performed more than 200 live workshops and delivered more than 400 lectures at national and international level. So, and above all, I know Dr. Sanjay Patel as a very nice and warm human being. It gives such a pleasure. He's like a big brother to all of us Gujarat gynecologists. So, welcome, Dr. Sanjay Patel, sir, and over to you, Sanjay, sir.
You are muted, Sanjay sir.
Before I start my talk, I tell you something related to our guest of honor, Dr. Pikesa. He is my MD examiner. Agar ye nahi hota, to I couldn't get the MD degree. And due to the blessed by the Dr. Pikesa, I received the MD degree. Second, I spoke related to Dr. Prakash Trivedi. हम भी इसी सड़क क्यों अभी निकलने जा रहे हैं और हम कोशिश करेंगे कि हम कितना करीब जा सकते हैं क्योंकि go back yet I not started this one. Let's I finish first and then you start this one. Can I start?
Please go ahead, sir. Please go.
Yes,
ahead.
sir.
Also, Dr. Prakash Trivedi is like the Jagat Guru Shankaracharya for the Foxy endoscopy, because ye nahi hote to we couldn't learn the depth of the endoscopy. My dear friend Dr. MC Patel, Dr. Bagde, Dr. Nirav Jadhav, Dr. Sudhir Shah, all are senior people. And very upcoming enthusiasm team from the Gujarat is Dr. Sejal, Dr. Sujal, Dr. Manish, Dr. Saswat Jani, and my dear friend Dr. Mahesh Gupta is also with us, because every time, I think, whenever we do the academics related to any subject, I think Mahesh is the one of the organizing persons. And also I say good luck to the Dr. Niranjan Chauhan for the treasurer post for the IAG. But I think today I see the Dr. PK Sai is in the different mood, different way. I think मुझे हो तो नथुलाल जैसे sir. I'm impressed with this one, and I think I am the most discarded guy in the field of medicine. But you blessed me to I received the MD degree. That's why I reach up to this stage. So I start my subject related to this bowel involvement in the endometriosis. With the very important subject is the rectovaginal plate. If you understand the rectovaginal plate, all the things related to bowel involvement and endometriosis is easy. Next, please. Next, please. Next, please. So I think just 1 minute, go back. This is the typically diagram I drew myself, and the visual effect is created by my IT team. If the serosa is already involved, but not the muscularis involved, in these cases, the rectal nodules is the one of the right answers. So I simplified into this diagram. Next, please. If the muscularis is involved, but the mucosa is not involved, in this cases also you go the sieving technique, and even though you preserve the mucosa of the colon, so it's reduced the morbidity. Next, please. But when the mucosa is involved, muscularis is involved, and the lesion is less than 3 centimeters, in those cases you go for the discoid dissections. And I think this is the one of the approach everybody is learned at. Next, please.
સંજય ભાઈ,
Yes.
વિડિયો છે ને, વિડિયો?
Yes.
હા, તો એને વિડિયો પ્લે કરવાનું કયો. જ્યારે બી તમારે પોઝ કરવાનો ને પોઝ કરવાનો. નેક્સ્ટ ઉપર
I think the few slide is related to sir only discussions.
Okay.
This is the whenever the multiple nodules with the lesion is more than 3 centimeters, in those cases the rectal resection is required. Next. And the hourglass structure, it's the circular ring like hourglass structure. In those cases, we have to have the go for the use of circular stapler and bowel resections. Next, please. Endometriosis surgery like the mathematics. If you understand 1 + 1 make 2. Next. Endometriosis still is the enigma. We all are still not ever the real reason of the disease, but we know the certain fact based on which the present treatment is designed. Might be this one is the present scenario, might be future is absolutely on the different way. Next, please. The principle of the endometriosis surgery: understand the alter anatomy, find out the correct plane of cleavage, because it's the alter or abnormal plane. You have to have the correct the plane of cleavage. Debulking surgery, because it's without debulking of surgery you couldn't enter in the pelvis. Understand the tissue texture, and epicenter of the disease is the main key part to find out, because the whole fascia and everything is migrated toward the epicenter. Next. This is the one of the technique we developed for the butterfly technique for the removal of the implants of the peritoneum and rectovaginal plate. Next. Now we continue with this video. I think this is case small implants over this particularly on the bowel, and we try to make the same over it because it's not involved in the muscularis portion of the colon, and harmonic is considered to one of the best tool to be excised parallel to this serosal surface of the colon. And sometimes it prefer to use the seizure because with the seizures we get the tactile sensations. And flush to the nodules, if you remove it, you try to make the save the muscularis portion of the colon and indirectly to prevent the complications like the fistula with the seizures. So I think this is considered to be one of the saving technique. And the small nodules look here over this colon, it's like the tip of the iceberg. But I think what I'm telling today related to rectovaginal plate with the peritoneal involvement, because it's a multiple implants over this peritoneum. We started this work quite long back in the 2012. So many people is narrated related to this butterfly area, but none of the people I think related to show the technique, how you I think creating the butterfly technique. I think we started this work quite long back in 2012. And we extremely happy with this one because it is not related to only patient is relief from the pain and everything, but it's reduced a lot of recurrence rate of this disease, and fertility outcome is also very good. So we try to make the, I think, remove all the implant over this peritoneum associated with the posterior colorectal plate. And particularly the such kind of the dissections, you have to have the understand related to medial pararectal space. Because this, all the gynecologists learn the technique related to medial pararectal place. But one thing you take care, you try to make do the nerve sparing surgery and try to make avoid the injury of the hypogastric nerve. If you preserve the hypogastric nerve, it may be related to bowel and bladder complication is much more less, and it may be, I think, indirectly interfere related to bowel mobility. Particularly in this technique, also we enter and try to make the split the rectovaginal plate, and you enter in the two layer of the denominal space here. And one of the important part, this is sometimes it's the plaster peritoneum with the fibrotic peritoneum. You have to have remove it, and you do the fiber to fiber dissection in such kind of the cases and try to make clear all the implants over this peritoneum. Because the ureter is the first victim in such kind of the cases. If you leave the small implant left behind, there is ample of chances in the future to patient is presented with hydronephrosis and hydroureter. So I think this is one of the technique we created, the butterfly. Professor Khaleesi, Professor Mario, so many people is, I think, tell related to area of the butterfly technique, but no one can demonstrate it. And my son, Dr. Smith, started to publish this work related to our butterfly technique. And we extremely happy. We've done since last 8 years, and we extremely happy with this technique and this approach. And look here, this is we lateral mobilize the hypogastric nerve. We enter in the middle pararectal place, and we try to make excise all the body. The central body is the rectovaginal plate, and the peritoneum over this the broad ligament, and over this the uterosacral. This is the two wing of the butterfly. So we remove in and block. But the most important part to mobilize the colon properly. This is the two layer of the denominal space here. We mobilize the colon properly, and then we excise with the end block dissections of the peritoneum, posterior peritoneum of the broad ligament associated with the peritoneum over this uterosacral, and this is the rectovaginal plate. We excise it. So very important to now we try to make the understand related to rectovaginal plate for the endometriosis surgery, and this is the really future related to its outcome. And one important part, I think it's so easy if you started flush to the peritoneum and try to make the straight, it's easily came out this peritoneum. What we done the peritonectomy in particular in the CA malignancy, same way, only we get some fibrotic lesion over it. So I think we require the more force to dissect the properly. And look, this is the like the butterfly, and that's why we call the butterfly technique associated with the colorectal plate in between. But the another one important, I tell you, always such kind of the multi-lesion associated with the bowel involvement. And look this looks the tip of the iceberg. The main lesion is below to this particular tip of the iceberg, and you have to have excise this one. This patient have the bowel problem with the dysphagia, and even the patient is suffering from the constipation during the time of menstruation. So this is the one of the major problem associated with this patient. So we try to make the remove even the this nodules. This nodules is approximately 2.5 centimeter, but it only looks outside only the 2 mm. And the seizure is considered to be best tool. Try to make the flush to the nodules. But one of the important part, I tell you, have to have the excise the everything. Because if we leave the small tissue left behind, there is ample of chances of the recurrence because we preserve the overhead. This is the fertility enhancing surgery associated with the removal of these nodules. Particularly in this cases, the rectal mucosa is not involved. So we try to make the flush with this one, and also we try to make the preserve the mucosa of the colon. And some lacunae collection, you have to have the excise all the cyst wall. It's very important because lacunae collection in the colorectal nodule is work as a volcano, and it's presented with the severe dysmenorrhea and menorrhagia. But if you preserve the mucosa of this colon, I think the post-operative morbidity and complications rate is much more less. And even though you go for the single layer closure with the vertically, it's also enough. There is no need to take the transverse suturing in these cases. But the good bite of the muscularis portion of the colon is very important. You go depth in the muscularis portion, and you can move. So good approximation of the muscularis portion of this colon is very important. And we started the liquid, particularly in this case, after say 6 hours, and majority patient is started the soft diet after 24 hours in such kind of the cases. And believe me, if you try with this technique, I think the recurrence is very late, and even the patient is enjoying the good quality life. Because what we done, not only the related to fertility part, the most important part is give the quality life of the patient. And the first surgery is very important. Whenever you perform the first surgery, try to make the eradicate properly. This is another one case. 24 years old patient is took the Jonadex 3 doses. Associated with the patient is also took the Dynogest. I tell you, the Dynogest and Jonadex is really worst. It's created a lot of fibrosis. Why I specifically put this case? Because the loss of elasticity of the tissue and the surgery is become the more difficult. And all fibrosis is created over a period of time. What's happened in the corona? I think lung fibrosis is happened and it may be permanent. So I think Zoladex and Denajos is such kind of the diseases create the permanent fibrosis of the particular disease tissue, and that's why patient is suffering from severe pain in the pelvis. Not only the related to during the time of early menstruation, but if the patient is took the more Zoladex or Dynogest for the longer time, this pain is persistent for the whole months. So try to make the understand. I think never misuse the Zoladex or Dynogest like drugs like the Chanamambra, because it's encountered the so many complications. And even though in this same case, this is associated with the colorectal plate. So we have to have the excise the all colorectal plates associated with the wings of the peritoneum. And also very important to, I think, do the nerve sparing surgery, avoid the injury of the hypogastric nerve. Because if you save the lateral mobilization of the hypogastric nerve, it's create the wonderful outcome related to bowel and bladder issue. If you damage this such kind of the cases to damage the hypogastric nerve, it maybe create the problem related to neurological problem related to bowel, and patient is maybe have the persistent problem related to constipation and everything. And this is the, I think, hold the nodules with the colorectal plate. Why I specifically told that the bowel involvement majority associated with the colorectal plate. So you have to have the posterior cervical pathology between the colon, between the upper surface of the pouch of Douglas and posterior cervical. You try to make the excise in bulk. Here also on the lateral side of the colon, it's the deep infiltration with the endometriosis. The one of the important part in this case is because we couldn't get the mobility of the tissue. Then surgery is more difficult. Plane of cleavage is sometimes difficult. We try to make the flush to the particularly peritoneum, but you have to have the excise because this disease is the corrosive and infiltrating nature of the endometriosis. So you have to have the go in the depth and excise the infiltrating disease properly. Then patient is get the enjoying from the free from the pain. So I think this is the whole peritoneum associated with the rectovaginal plate. And this is the same technique we follow since many years. This is the butterfly technique. I couldn't publish it. Recently, my son started to work over on related to this outcome related to butterfly technique. And this is, look here, this is the whole colon is densely adherent with these colorectal nodules and associated with the transverse whole plate. Sometimes it may be associated with the uterosacral involvement and maybe cardinal involvement. So also you look related to ureter, because such kind of the patient may be presented with the hydronephrosis and hydroureter. This is the whole disease is involved on the lateral surface of the colon. So we have to have the exercise. And Dr. Sailesh Putamir always telling fat is belongs to the bladder, fat is belongs to the rector. So you keep conscious whenever you dissect the lateral surface of the colon and you exercise the whole the disease lateral border of the colon, you very consciously I think try to make the find out the plane of cleavage. And if you find out the any muscularis injury of the thermal injury at that side, just you suture properly, you take the 1 or 2 stitches, it's prevent the complications like the fecal peritonitis. But one of the important part is the victim of the ureter. Look here in these cases. I think the ureter is displaced medially, so you have to have the clear properly associated with the uterosacral involvement. This is the left uterosacral involvement. And the new, I think, harmonic probe, I think this is the class 1000. It's designed particularly for the endometriosis surgery, even though it's a very expensive, but it's very done precisely work and make the plain blood less. So I think your surgical job is much more easy, particularly whenever you use the proper instrument in such kind of the cases. So this is the also now we dissect near to this rectovaginal plate, and also we excise the whole rectovaginal plate with the wings of the peritoneum affected with the endometriosis. At the end, just you look this one. So this is the whole plate with this peritoneum, and if you properly dissect it, you find out the clear, crystal clear pelvis. Now the most important part to, I think, you separate the colon from the vagina. It is like the also cesarean section. In cases of the previous 2 cesarean section, if you go below to the, I think, scar area, you find out the good plane of cleavage. Same way, if you go lateral approach in such kind of the cases, you get the good plane of cleavage, and the colon is mobilized gradually from the vagina. Once you get the good mobility, then you deal with these colorectal nodules. Look here, in these cases, also this is the 1.5 to 2 centimeter of nodules, but it invades the mucosa of the colon. So I think you have to have the open the particularly colon, because you excise properly. You couldn't leave the small left tissue behind it. Here I open the colon, I excise properly, I get the good tactile sensations plus to the nodules. Because I think we realize that if you excise properly, this patient is immediately free from the bowel problem and even the dysphagia. And Indian doctors is, I think, excellent for the intracorporeal endosuturing. I think because European people is not accustomed with the intracorporeal endosuturing, and that's why these people use the half circular stapler in such kind of the cases. But believe me, I think this suturing is much more easy. You try to make the understand the principle. Better you transverse the suturing, take the stay stitches laterally, and first stitch may be continuous from the muscularis to mucosa. The most important part related to this suturing is you invert the mucosa inside. Anytime you feel the pop out of the mucosa, you try to make the bury with the double layer suturing. So I think if you do the proper suturing, if you go for the single layer suturing is also fine. But if you find out any mucosa is pop out, then you go for the double layer suturing. And a good chunk of the muscularis portions, seromuscularis portion, you take for the second layer suturing, you approximate properly. And I think it gives a wonderful result compared to this stapler. I think we get the equivalent result with the suturing, and we're very happy with the bowel suturing with the 30 Vicryl. But at the end, I show you one thing. Even the 2.5 diameter of the rectal probe is passed through this below to this suturing. This is very important because so many people believe that if you go for the colonic suturing, there is ample of chances of the stricture of the colon. But we done the very big series related to such kind of the discoid dissections. We done it, and we realized, look here, this is the 2.5 centimeter of the probe is, I think, passing through this colon. And I think such kind of the cases is never presented with the stricture, and it gives the wonderful outcome. And no need to do the nil by mouth for the longer time in these cases. I think only just you give the liquid after 6 to 8 hours. This is very interesting case. I think this case I operated before, I think 7 years back. At that time, patient is presented with the hydronephrosis and hydroureter. We go for the ureterolysis, we put the stenting, and then we took the support of the IVF. This patient delivered the female child before 5.5 years back. And again, she presented because this, in particular, this case, this is the circular ring. This is the hourglass structure. What I tell the Motabai, it's a hourglass structure typically. And in these cases, I think you have to have the go for the resection of the colon. I always prefer, because urinary people is not believed to particularly ligate the mesenteric artery. But in these cases, this associated with the non-functioning kidney. And patient is presented with the so many times with the fever, with rigor, with the pyelonephritis and pyloureter. So I think we decided to go for the, because it's the cardinal involvement, and that's why the patient is presented with the non-functioning kidney. So I think we perform the nephrectomy in these cases, because if you know the severity of this disease, I feel it's extent, because ureter is the first victim in endometriosis. Never take very lightly. This is the take-home message related to this case. Because in spite of that, I do the good ureterolysis, I do the stenting and everything. Over a period of time, patient is presented with non-functioning kidney, and this is the ureter. In this case, I think that previously, I think we done the cesarean section in these cases. The whole colorectal plate is like the plaster. Look the texture. This is absolutely different texture with the circular ring involved with the uterocycle, with the cardinal ligament, even the parametrium. When parametrium involved and cardinal involved, then and then patient is suffering from the hydronephrosis and hydroureter. So I think that sonography is the one of the key part to, I think, realize that even though we tried with the MRI so many times, we tried to make the taught our MRI team people, but I think we couldn't succeed properly. So I think we also not much more rely on the MRI. And we believe that transvaginal sonography and good PR examination, it gives the very good outcome. Sometimes if we prefer patient is presented with the bleeding PR in such kind of the cases, also we prefer to go for the even the colonoscopy. But I think the good PR examinations with the transvaginal sonography give the related to involvement of the bowel, also involvement of the cardinal ligament and parametrium. So I think we try to make the parallel to the ureter, just we lift up it, and this is the whole cardinal with the parametrium is involved. First we mobilize the uterus, because uterus is also densely adherent with the anterior abdominal wall. And the bladder mobilization, it's not much more difficult. Majority time in the endometriosis, we get the good plane of cleavage for the bladder mobilization. But in cases of the bladder is involved with the endometriosis, in these cases you felt the difficulty. Now we parallel to the dissect the middle pararectal place, and we enter the between the colon and sacrum. This is we call the holy plane. So I think it's very important whenever you go for the bowel resection, in these cases you enter in the holy plane, try to make the mobilize the colon. It's such a easy. Each and every organ, particularly in the body, have the two fascia. And you are between the two fascia, I think that always you get the good plane of cleavage. And look here, this is the, I think, fibrotic rectovaginal plate associated with the lower upper 1/3 of the vagina involved, also associated with the parametrium involved, with the circular ring. First, I show the, I think, cardinal involvement. We dissected properly the cardinal involvement with the stricture of the ureter. So we excise the cardinal ligament, and also we apply the clip and just we free this ureter from this cardinal ligament. And furthermore, we try to make the parallel to the, always, again I tell you, if you go the lateral plan, you get the good virgin area. And try to make the start from the lateral to the middle, you get the good plane of cleavage. Sometimes I prefer to split the nodules. because splitting of the nodules, particularly in the middle approach between the vagina, uterus, and rectum, I think middle approach is also very important part to free this colon. And we try to make the bring the hold the nodules with the colon. So this is the one of the key part. We mobilize from the anteriorly, laterally, and posteriorly. And this is the area of the two layer of the denominal fascia. This is the lesion is more than 4.5 centimeter. Further, we try to make the bring the whole the vascularity with the one layer of the denominal fascia with the colon. We dissected with the harmonic scalpel. And one important part, whenever you, I think, apply the stapler, try to make the remove the all the fat, because fat is really nuisance. If during the anastomosis side, if the fat is come between in between, there is ample of chances of the leakage. And second important part, we personally believe is European people is not believed to, I think, ligate the inferior mesenteric artery. But we, I think, very happy to, I think, ligate the inferior mesenteric artery and wait, and we cut it. So we get the mobility of the particularly colon, and there is a give the tensions free anastomosis. So this is the key part in our center. We believe that try to make the inferior mesenteric artery, and its tightening is happen colon, and also the lateral fat we try to make the excite, and we try to make the naked the colon. This is the key part. You excise the whole the fat over this colon, and as far as possible try to make the do the naked of this colon. So now you look at this fat is, I think, no more with this where we apply the stapler. I prefer to use the 45 mm stapler. Sometimes I prefer to 1, sometimes I prefer to the 2. And this is the, I think, because this is the case for the hysterectomy, so we use the natural vaginal orifice, and also we try to make the remove the fat parallel to this colon. We try to make naked as far as possible. We cut with the harmonic scalpel. We put the anvil inside, and this is the whole stricture area. Also, we prefer to take stay stitches with the Prolene 30. This is very important because we fix the anvil. If you not properly fix the anvil, it creates the problem. So I think we fix properly. We push back inside. Further, we more clear the fat. Once we put it, then we push the plunger from the below through the anus. Before that, we fire this stapler. I think we check the integrity of the colon and axis rotations. You correct the axis rotations. This is very important. So we properly correct the axis rotations. We check related to colonic axis properly. And we look the mesentery of the colon, and then we fire the stapler over it. And look, this is the end result. We are extremely happy. But one take-home message from my side, I think such kind of the surgery you preserve. If too good loop, I think this is the signs of the proper anastomosis. Accordingly, I think you reserve for some specialized cases, because we also believe that endometriosis is the benign disease. Please stop it 1 minute. Please stop it 1 minute. I think this is the kidney with the involvement of the cardinal ligament with the ureteric stricture, and this is the colonic nodules more than 4.5 centimeter. The take-home message, it's the benign disease, behave like malignancy, but I think it's the localized recurrences happen. So optimizing surgery is key part. The last case I took the 3 minutes, because majority now cases is patient is underwent go for the hysterectomy, intrafacial hysterectomy, and patient is presented with the bowel problem like dysphagia, constipation, and pain during the defecations. So look here, this is the case, even though this is the 4.5 centimeter colorectal nodules left behind. And after the 6 months later, the same problem persisted with this one. This is the same. The most of the key part, even though you go for the discoid dissections, better you mobilize the proper colon. This is the key part of the related to this colorectal nodule surgery. And also we dissected from the plate, from the rectovaginal plate to the colon. This is the two important part, because and then we prefer to take the stay stitches on the laterally, because in these cases we couldn't use, even though up to the 4.5 centimeter size of the colon, even the TOG is never allowed, because more than 3 centimeter people is telling for the use of the circular stapler. But we have the series of cases and more than 3 centimeter of the colorectal nodules. We also deal with the discoid, and we extremely happy none of the cases is presented with the stricture of the colon. So I think harmonic is best too. We use the seizure, we flush to the nodules, we try to make the excise what the affected mucosa, and all the lacunar collections, cyst wall, we also excise it properly. But then we open the colon. So this is the nodules is more than 4.5 centimeter, but this is the something different work we are doing, because I think even though people is not agree with us related to this part, if the lesion is more than 3 centimeter, you go for the use of circular stapler. But we done the couple of cases and we extremely happy, because if you go for the discoid, because this is the anterior pathology of the colon. Because if you use the circular stapler, you invades with the so many nerves and you compromise the nerve of the colon and everything. For the first 6 months, patient is presented with so many problems related to frequency of the stool, pain during the passing the stool. So I think if the anterior pathology, you only concentrate for the anterior pathology and preserving all the nerve supply, and only the segmental excisions. This is we call the segmental excision of the colon, and it gives the wonderful outcome, and it's reduced the post-operative morbidity, and even the hospital stay is much more less compared to the what we prefer to use the circular stapler. So I think another it needs the sometimes to the comment related to this part, because we need the large series. In those cases we deal with the more than 3 centimeter size of the colorectal nodules. And at the end, we took the mesentery of the colon and just we fixed it. We not believe in the omentum patch, because omentum is a work as a policeman. Any injury we done in the intra-abdominal, omentum is automatically reached there, because this one is the real police for the abdomen. And that's why we believe that there is no sense to keeping the omentum. Sometimes artificially, if you suture with the omentum, it's create the dragging pain for the patient for the longer time. And if once any injury happen over this at the site of the colon, the omentum is reached there, it's fixed with this one, and over a period of time, fibrillary activity is happen, it's automatically separated. Thank you very much. Thanks to the Dr. Niranjan Chauhan and all the august audience. I think today I am extremely happy, because all my respected teacher, respected gurus, and all the dear friend of mine with us, even though this is the very small audience, but it's the much more benefited for the me. And thank you very much to Dr. Niranjan to I deliver this talk related to in the front of this august audience. Thank you.
Wonderful presentation, sir. And I want to tell you, the audience has increased to 589. When the video started playing, more users started coming, and Dr. Prakash Trivedi sir and Sanjay Patel, you are amazing in myomectomies, and I think nobody is par excellence as a surgeon in the field of endometriosis. I only know Horace Roman from France. He's a surgeon, and we had also called him for an international webinar. And Basma Darwish, his student. But as a gynecologist, when you have gone beyond and stretching the limits of a gynecologist, and that is what is Sanjay Patel at Mayflower Hospital, and it's amazing. I want to read a comment of Dr. Atul Munshi sir. He's also joined, and he has said, Dr. Atul Munshi sir, nice talk by Dr. Prakash Trivedi, excellent clean dissection Sanjay bhai. And there are many wonderful comments and appreciation by the viewers who have put in here. I'm just reading some of them, and it's amazing. Wonderful, sir, the way you have done. Sir, I want to ask you yes, sir. I want to ask you one question. Do you need to do a colostomy for these cases, or you just suture it in 2 layers?
I think one of the criteria we believe that if this one is from the anus to the less than 8 centimeter size, if you go for the below resections, majority time discoid above the level of 8 centimeter. It's near to the plate of the rectovaginal plate. Okay, so it's I think in this case is no need of that. Just we suture it 2 layer transversely is fine. But if sometimes it's the nodules is invasive inside and it near to this, if this one is the less than 5 centimeter anastomosis, in those cases you have to have the go for the diversion. I prefer to do the ileostomy rather than the colostomy because the smell and everything is much more with the colostomy, and the ileostomy is much more, I think, easy to even though reverse this one. So we prefer to do the ileostomy rather than the colostomy. And second important part is because what's happened if the lower segment sometimes is couldn't, because everything is stretched much more, and once the colon is press it, there is ample of chances of the leakage. So I think above the level of 8 centimeter, no need of ileostomy, but if the below the level of 8 centimeter, better you go for the diversion.
Wonderful, wonderful. Sir, one more question, sir. Post-operative management, which has been asked, and there is one appreciation from Dr. Chong Hyok, South Korea. Very nice presentation by Indian doctors. I think Indian surgeons, gynecologists are amazing. They are par excellence. They are more better off, I'm sure, and it has been proved by our seniors and predecessors. And the presence of Dr. Prakash Trivedi, Sanjay Patel, Dr. P.K. Shah sir, MC Patel, and we have a luminaries of panelists being with us is itself to speak. Thank you, sir. I want your opinion, sir, about post-op management. Yes, Trivedi sir, I'm coming to you.
Yeah. No, I want to make one very important statement before your question. So many people have come and been trained under us, and I'm so proud that all my students have become billionaires in terms of skill, not in terms of money. So amongst 4 or 5 world's best endometriosis surgeon is Arno Vatius, Redwine from America, Marshalo, and undoubtedly our Sanjay Patel. 2 patients were so difficult for me. In fact, I told them there's only one person who will handle your case in India, and I have sent this. Sanjay is a brilliant brain, and we are happy. As you rightly told, we are blessed by P.K. Shah and all the other people, and it's a great thing.
Thank you, sir. Sir, the post-operative, how many days you will be keeping NBM? That is a question.
I think when we started this work in 2003, we are very scared, and at that time we, I think, follow with our old protocol. So we do the 3 days nil by mouth, then we started with the water, and then on the 5 days we feel that we started with the liquid form, and the up to the 7 days we give the soft tight. But 2004 we realized that even though we spoke with our obesity team and everything, because the Dr. Mahendra Narvare started the obesity surgery, and he started the liquid after the 6 hours, after the use of stapler and everything. So he told me, I think, Sanjay, because there is so much secretion in the colon, I think every day it's more than 3 liters of the secretion in the colon. So there is no sense to keeping the nil by mouth. Second important, once you start with the nil by mouth, it's increase the mobility of the, decrease the mobility of the colon. So there is ample of chances of the paralytic ileus and everything. And then we started with after the 6 hours later on, we started with the clear liquids. And after 24 hours, again, we started with the same clear liquids. Once patient is past the flatus and stool, then we start for the soft tight. So I think within 24 hours, our BG came to start the liquid form. And even the once the patient is past the stool and flatus, immediately we start the stop tight. And I think there is no need of much more hospitalization in such cases, only for the 48 hours. And I think we give the soft diet. Still, we are gynecologists. We still afraid related to this part. So I basically told to my patient, better you keep the soft diet at least for the 3 to 4 days, and then you start the solid diet.
Thank you, sir.
Sanjay.
Yes.
Yes, Mahesh.
Yeah, please elaborate about the 8 centimeter criteria. What is that? I could not understand that.
This is from the NS to the where we apply the stapler.
Okay.
Actually, we go below the rectal fat, and we apply the state stapler over this colon, If this one is less than 8 centimeter, it's very below to the this near to the anus, then we go for the diversion. It's more than 8 centimeter. I think because the expansion of the particularly this colon, if we realize that it's less than 8 centimeter. If this one is above the 8 centimeter, there is no much more expansion related to this part, and I think there is no need of ileostomy in these cases.
Rationale of putting this question that most of the vaginal surgery, the most of the injuries in the rectum, it is less than the 8 centimeter.
I think
so that is the rationale of my question putting to you.
Yes, you are absolutely right.
Yeah, in case of vaginal hysterectomy or in case of any vaginal surgery, if we are tackling the rectal injury, because most of the time it is less than the 8 centimeter. So in that case, what do you say, that ileostomy is to be done or it is to be sutured vaginally?
I think because whatever we find out the injury at the near to the posterior cervix, okay, in the pouch of Douglas. And if you do the straightening, if you dissect the denominal fascia, recto-vaginal fascia, if you enter and you stretching of this one, majority time it's the more than 8 centimeter. So I think the injury is happening at the side of the pouch of Douglas when you open the posterior pouch, and we encounter the injury. In those cases, if you go for the primary 2-layer suturing, most probably prefer to do that transversely. I think it's enough, and it's a clean-cut injury. I think there is no require of diversion. Even everybody, those who are doing the much more vaginal surgery, everybody has faced this problem once in life. And I think everybody is doing the primary suturing with the 2-layer of the colon.
Yeah, that's true.
Thank you. Thank you
so much. Mahesh, because what we thought that the vaginal length, the posterior vaginal length is always more than 8 centimeter, majority cases. If you put the speculum and further you mobilize the colon, because colon is dilated on the below to the vagina. It's like the dilated portion. If you stretch this one, is always more than 10 centimeter. If you dissect it properly from the posterior vagina and then you stretch that, it is always more than 10 centimeter.
Yes, Dr. MC Patel, then we move ahead to the panel discussion.
Yeah, can I?
Yes, sir.
Yes. So, as usual, both the speakers were excellent in their deliberation, but as an medical legal counselor, I would like to put some comment. Because in this type of surgery, either it is myomectomy, and rightly pointed out by Dr. Prakash, whether it doesn't matter number, place, size, agree. But I think real and valid or informed consent or counseling is very much important because many a times, if at all any morbidity happens, then it may create a problem and it may lead to a shoe. Same way in endometriosis cases, rightly discussed by Dr. Sanjay, but possibility of trauma to rectum, rightly pointed out by Dr. Mahesh Gupta also, this also should be counseled prior the surgery, that there is some possibility that rectum or any colon may get injured and further surgery may be required, whether it is open or anything else. So if we have counseled patient like that, then it minimizes the chances of litigation. This is my expert comment as far as medical legal part is concerned. So again, congratulations Sanjay and Dr. Prakash for excellent deliberation.
Thank you. I was going to come, and that's why we have a medical legal expert. Because when we are dealing something which is beyond the purview of the gynecologist, but it doesn't mean that a gynecologist cannot stretch the limits, and that's why we have got Dr. MC Patel. Thank you for that wonderful point which you have done and which you have given to all the viewers who are there. Dr. Prakash Trivedi sir, there are many comments for your expert myomectomy which has been showed by you. Excellent talk and video presentation by Sanjay Bhai, as always mesmerizing. This is Dr. Sunil. Dr. Shashwat Jani says, thank you Sanjay Patel sir and Prakash Trivedi sir for a very informative, to the point talk. And I'm really happy. There are many, but I can't just go through it. I thank both of you, our teachers, and we go ahead with our panel discussion. All are set. Thank you for all of you being here. And Dr. Pikesha sir, just half an hour, if you can please
I'll
stay.
be with you. I'll
Yes,
be
sir.
with you.
Yes, sir.
Don't worry.
And I want your special comments, sir, after these two lectures. Just few words. Then I will start with the panel. Without that, I can't start.
Mesmerizing. I think if I have to really tell you in one word, and Sanjay, I'm really happy to see the world-class surgery that you have shown. And as very rightly told by Dr. Prakash Trivedi, you are in one of the 5 top endometriosis surgeons in the world. And that's very true. You are a bold surgeon and you're doing something new, something which a general gynecologist won't do. And they will keep sending these difficult cases to you in Ahmedabad. Good you shifted from Mehsana to Ahmedabad so that people have gotten access to a fantastic endoscopic surgeon in the center of Gujarat. Thank you and all the best for all the surgeries that you do, and I wish you success in these difficult endoscopic surgeries. Hi Mahesh.
Thank you, sir. Thank you for the kind words, sir.
Thank you, Sanjay Bhai, Prakash sir. And I request now to introduce our esteemed panelists. This program was decided 2.5 months back, and today on 13th of September, we have seen it materializing. And I would like to welcome our esteemed panelists. I have tried my best to involve endoscopists, general gynecologists, IVF consultants, senior gynecologist, middle-aged gynecologist, and our junior budding stars in IAG, in Foxy. So I welcome Dr. Mahesh Gupta, sir. We know he has his own practice, and I have been witness to his wonderful hospitality in Ahmedabad city. He has more patented and published techniques which are commonly and famously known as COMOC MG operation, and I have seen him operating in workshops at Sion Hospital, at Cooper Hospital, and other places. He has done a lot of workshops. I can imagine and I remember during Dr. Ishma Pai's time as a Foxy president, he has done more than 80 to 90 workshops. If I am wrong, please you can correct me in the numbers. But he has gone to nook and corner of small towns and cities and showed that apart from B-Lynch, apart from Chow sutures, we have something Indian and it has been patented and it is COMOC MG operation. He has his own 50-bedded multi-specialty hospital, and we also know his tenure as the president of Ahmedabad Obstetric Gynec Society. Welcome, sir.
Thank you.
Then I call upon Dr. Munshi. Dr. Munshi, Sujal Munshi, is the next generation gynecologist from the Munshi family. He has his own setup, that is Kalpana Munshi Hospital. We know that it is his 3rd term as the elected board member of Indian Association of Gynec Endoscopy. And he is a very active member in Ahmedabad Obstetric Gynec Society, Nova IVF Ahmedabad, PS Medical College. We have seen him conducting courses. Yes, he's not only having his own hospital, but he has also training courses which are tied up with France. And I welcome Dr. Sujal Munshi. Well, another famous personality. He has got more likes on Facebook and he is a very active member in Ahmedabad Society. Presently, he is a secretary of Ahmedabad OBGYN Society and joint secretary of Foxy, taking and helping Dr. Alpesh Gandhi in this presidential tenure. He has special interest of RPL and RIF, received many awards in Ahmedabad Society and in Foxy. And I would like to name the Gujarati Shreshthi prestigious award, which was bestowed on him by none other than the Honorable Chief Minister of Gujarat, Shri Rupani Sahib. Thank you so much, Dr. Sunil. Join us. Well, we have to have one lady with us, and this lady is none other than a beautiful lady of intelligence, of beauty and grace and elegance, Dr. Sejal Naik. We have seen her doing endoscopic workshops in Surat, and she is also the committee member of Indian Association of Gynec Endoscopists. She has also been honored with the Foxy Young Achiever Award in 2018, the SOGS Star Award, Best Paper Award in All India Congress of 2019. And I want to tell you one thing. She has a wonderful hospital. I have been there. Belly and Love, that's Women's Care and Rahul Hospital in Surat. And she has got one beautiful accolade and wonderful important milestone in her life, that she's the first gynecologist to perform a single incision laparoscopic hysterectomy in Gujarat. Welcome, Dr. Sejal. We have with us a professor. I have met him many times in conferences, but we all know that this guy is always distributing the famous groundnuts of Surendranagar, and I have been at his place. He's a so kind man. He's a very kind person, and he is the head of the department. He has his own hospital. Very learned person, research oriented. He has his own training center, which are Foxy recognized for ART, IUI, IVF, ICSI, and has done more than 524 presentations. I don't know, Manish, how do you keep this count? But welcome. We have an interesting case for you. Thank you. And we have the younger brigade represented by Dr. Shashwat Jani. He is a consultant assistant professor at Srimati NHL Municipal Medical College, Ahmedabad. He has been in the managing committee as a member of AOGS, Chief Coordinator, West Zone Perinatology Committee, and he has been trained as a master trainer in Foxy John Hopkins Safe Motherhood Initiative. He has published more than 18 articles in index journals. A young dynamic man. I see him in conferences. Welcome, Dr. Shashwat Jani. So with this, I would like to share my screen, and we would like to go ahead with the first case. One minute. Sorry. Well, I would request now Dr. Mahesh Gupta to start presenting his case, case number 1. Sir, please go ahead and read it.
Yes, Niranjan.
Welcome, sir.
It's a 38-year-old Paris woman who underwent laparoscopic supracervical hysterectomy and sacrocervicopexy secondary to grade 3 asymptomatic apical prolapse. I think this is 1 year back. Okay. History: earlier was admitted with chronic pelvic pain that has started 6 months following surgery. Vaginal examination, deep vaginal palpation was painful. Ultrasound, transvaginal ultrasonography revealed an area with hypervascularization on sacral promontory. She was scheduled for diagnostic laparoscopy. 2 by 2 centimeters solid wine-colored hypervascular hemorrhagic lesion was seen on the sacral promontory. So, what will be the management approach? And the second question is, what is the surgical procedure and how to manage?
Yes.
So, should I start commenting on it?
Yes, sir. Yes, sir. It's all the floor is yours. The mic is yours. Please go ahead. We have 600 viewers now seeing you live.
Yeah. Can we go back to the case now, Dr. Niranjan? Yeah. So, 38-year-old Paris woman underwent laparoscopic supracervical hysterectomy and sacrocervicopexy secondary to grade 3 asymptomatic apical prolapse. So I must congratulate that hardcore laparoscopic surgeon to operate this patient by laparoscopy and doing a sacrocervicopexy. So now the cervix, I understand that cervix is inside. Now go forward, please. So on the diagnostic laparoscopy, there is a mass 2 by 2 centimeter, and on ultrasonography is showing a sacral promontory with a hypervascular mass. So I think before going for a laparoscopy, I would like to investigate that mass. And in particular with the histopathology report of the uterus which has been removed. Does it have any connection with that or not? Or if we simply considered that this mass to be operated, then before going for the operation, we should investigate that mass, because the mass, isolated mass at the sacral promontory may be anything. Maybe a gynec or maybe a non-gynec thing. So before putting anything, I would like to first go for the investigating that mass by sonography or by MRI, and then we can go for a surgical procedure to remove that mass. And considering it is a gynecological benign gynec pathology like endometriosis, then here we have an expert like Prakash Bhai or Sanjay. They can easily operate these kind of the cases.
Yes, sir. So you would, what would that be a mass of? Dr. Sanjay Patel, are you there? Is it something related to endometriosis? Is it related to probably a clot which has been formed there?
That's why I told you, Niranjan, that histopathology report of the uterus is important, because if it comes to be a missed CA endometrium, then it is likely to get metastasized on that area. Because it is the bifurcation of the aorta, so aortic lymph node may get involved. And if it is purely a benign case, then there are different entity.
Sir, it was a benign case, sir. It was not a malignant case.
So in benign case now, the blood clot is never vascular. If it is a hypervascular, then it is something else. Blood clot generally on ultrasonography, it is never vascular, it is a just clot. And 2 centimeter clot generally it resolves by itself without doing anything. But it is a painful hypervascular mass.
Yes, sir. That is the problem. That is the problem, actually.
Yeah, it is a painful hypervascular mass. Then it is need to be investigated and then operated. And the differential diagnosis for that hypervascular mass at the sacral promontory, there are many such kind of the mass at the sacral promontory level, starting from endometrioma to hemangioma, to other mesenteric mass, to other neurological mass. It may be anything.
So absolutely, I agree. In this case, you should have a multidisciplinary approach.
Yes.
The surgeon has to be absolutely knowing what he is dealing with. And would you recommend an MRI before doing?
Yes, sure. Yeah. We should have a higher investigation like MRI or MRI venogram also if it is involving the blood vessels.
So that's what we did an MRI, and it was actually a very, very rare case. I had even talked to other sling surgeons who were there, and they had said it's very rare. We have not found any case. I want to share any expert, any opinion, or any comments by the other panelists on this case. Dr. Manish Pandya, I can see your hand up.
If you have MRI images or sonography images, then we could have we would like to discuss more about it. We should have some scan image, MRI image, or ultrasound scan image. Then we can comment upon it.
Yes, Dr. Manish, I can see you reading, and we have got now more than 800 viewers who are logged in, and I am so happy. They are not only from India, we have got viewers pan-India and Southeast Asia, and there are many going to come because this is the wonderful presentation. This is something which we don't commonly do in India. This was done somewhere abroad, and that's the case I got. And I discussed this with Dr. Horace Roman from France. This is a very rare case. Yes, Manish, I want you to add some suspense. I want you to add some or open the Pandora's box.
Niranjan sir and Mahesh sir, if you see, the mass is lying at the sacral promontory, and if you see the history, patient has undergone cervicoplexy for the apical prolapse, and the mass is wine color. So things there, so many times we can injure it, and without injury sometimes we can see the aneurysm of that local area, and that may
Yes.
become big. So that we can see on the MRI or Pandora's box. So it looks solid, but maybe cystic, but it has to be related with some vascular etiology, because color is wine colored, and maybe endometriosis. Now, Niranjan sir, open the Pandora's box with MRI images.
Sir, I want Sujal Munshi's opinion.
So once you said that it was done somewhere else, now it is very clear. In France, it is very commonly done that when you put a mesh inside, it has to be a subtotal hysterectomy, because you don't want mesh contamination from the vaginal flora. So this is a very common practice that in apical prolapse, they do a mesh, they insert a mesh, and when the mesh is fixed with the sacral promontory, there is a middle sacral vessel which is going from there. In normal circumstances, it is either dissected or coagulated. But many a times when you fix the mesh with this promontory, there may be hemangioma formation or aneurysm formation of the middle sacral vessel. So if that is the case, that may be visible at this point of time. And second thing, since you have preserved the cervix, and you usually after the mesh, once it is put, you make it retroperitoneal. So if there is afterwards endometriosis development, retroperitoneally, there is a chance that there may be a abnormal endometrial tissue which is near the sacral promontory and which is growing if ovaries have been preserved. So these are the two differential diagnoses, and ultimately after confirmation with MRI, you have to surgically intervene if it is a benign condition.
Yes. As soon as I said that this was operated abroad, Sujal immediately raised his hand and he got a hint. He got a hint of that. And Mahesh sir, it is absolutely right. They had done this surgery in France. And that's why we have such questions. We want something different. We have today bowel, we have got rectovaginal plate, we have got Dr. Prakash Trivedi being there, laparoscopic myomectomy, multiple fibroids removal, broad ligaments fibroid being removed. And that is what is the wonderful explanation been given. Mahesh sir, thank you for that wonderful presentation. You have gone in the right track. You just don't put a laparoscope inside. You need to do a proper MRI, proper investigation. And if you are suspecting either 4 of them, either aneurysm, it was a hematoma because of the sacral vessels, or it could be a wine red color, it could be something like endometriosis, or it could be something which is just being organized clot there. You have to have that vision. And that's what happened, especially in this mesh which was there. Yes, sir, coming.
Yeah, one thing also is possible that because of mesh, there may be an infection, and infection may lead to the neovascularization on that area. So theoretically, we can also consider the infected mesh on the sacral promontory, and that infection leads a neovascularization, and that may also be painful. Because simple hemangioma may not be painful all the time. So that is also one consideration for the differential diagnosis.
Yes. So actually this turned out to be related to the mesh sacral artery hematoma which was there, and it was evacuated properly, and that's what it was done. Thank you so much. We go with the next case now. I request Dr. Sujal Munshi to please read his case.
A 24-year-old married patient with severe dysmenorrhea and post-menstrual spotting for 5 to 6 months. In the menstrual history, it is painful menstrual periods, progressively increasing for 5 to 6 months. The pain especially severe around the time of her periods, to an extent that she cannot concentrate on her work and daily activities. She has tried numerous painkillers, controlled oral contraceptive pills without much relief. On ultrasound, bulky ovaries, adherent to uterus in fundal region with a 2 to 3 centimeter endometrioma and ground glass appearance, and pelvic peritoneum causing adhesions suspected on sonography with surrounding bowels likely suggestive of peritoneal seedings also. On MRI, findings consistent with the deep pelvic endometriosis with peritoneal kinking, with multiple loculated hemorrhagic and non-hemorrhagic collections in the periovarian region, bilaterally, suggestive of 2 to 3 centimeter endometrioma. Endometriosis also seen along the serosal surface of the anterior rectum, posterior surface wall of the urinary bladder, suggestive of pelvic endometriosis, and also involving rectal and bladder wall.
Yes, sir. So this is also a very interesting case. How will you manage this case? Please go on, and you can just read as you are proceeding with your answer, sir.
Niranjan sir, sorry for interruption.
Yes, please, you can tell.
Yeah, if we have so many delegates to watch this panel.
Yes, sir.
So can we have some carry home message for each case? Because we have a good endoscopic surgeon with our panel, so they can comment upon, and we can pass a carry home message to all the delegates that this is to be done or this is not to be done. So that is my suggestion, sir.
Absolutely, you're right. Yes, can I see the Dr. Sujal? Please go ahead.
Yes. So basically, how will you manage this patient? Now, if you look at the age of the patient, if you can just go one slide earlier. Yeah. See, if you look at the age of the patient is just 24, in early age of reproductive career. Though size of the endometrioma is less, her symptoms are very severe, and they are progressive. She has already tried medical management in terms of painkiller and control oral contraceptive pills. So further medical management, we have very limited options like a Dynogest or a GnRH analog, which we know have a very limited role in terms of duration of this thing. So would it have been a little later age? You can still try this, but at this age with progressive symptoms, for temporary pain relief, you can give some of the medical management like GnRH or Dynogest. But ultimately, sooner or later, she may require a surgical intervention because of her symptoms also. And at this point of time, though nothing about the fertility has been mentioned in this, we suppose that fertility is still an issue in future. So a surgical correction, keeping fertility in mind, should be offered sooner or later to this patient. And we have seen in the beautiful video that complete excision of the disease, considering her age and symptoms, is something which should be offered. And for endometriosis, we all know the first surgery is the best surgery that you can offer. So if it is done at a center where routinely this endometriosis surgeries are being done, it is always better. And if at all surgical intervention is to be planned, we may differ for any medical management because you may induce fibrosis and make surgery little difficult. So unless there are other contraindications for surgery, this patient can be offered a surgical intervention.
Yes, I agree with you. Any comments by anyone? Experts are there. I just received a message from Dr. Aspi Raimalwala. He is a senior gynecologist from Mumbai Obstetric Gynaec Society, and he has given the diagnosis of the first case as sacral artery aneurysm / hematoma. Dr. Mahesh Gupta.
Yes, sir.
Yes, sir. So it was a hematoma, as it was a sacral artery hematoma, and we need to understand that it has to be evacuated or it has to be kept there. Dr. Sanjay Patel, would you just answer that question, and then we will go to Sujal Munshi's case.
Can you hear me?
Yes, sir. Sacral artery hematoma, which has been there.
My sir, actually, this is the case of the deep infiltrating endometriosis associated with the bladder and bowel involvement.
No, not this case.
This case, I think bladder and bowel involvement.
No, Sanjay, we are talking about the previous case.
Previous case. Oh, I think in this cases, if the hematoma is small, patient is non-symptomatic, you wait and watch. I think couldn't jump directly to evacuate this one. But if this one is the bigger size and associated with some problem related, sometimes patient have the backache and pain. Because where you fix the tucker, where you took the suture, this is the most important. And sometimes patient is presented with the dragging pain over this leg, sometimes radiating pain over this leg. In those cases, I think you have to have the interval. This is very important. But if the patient is asymptomatic with the small hematoma, you wait and watch, you go for the
She has
CT.
got lot of pain, sir.
So in this case, better you evacuate, because only the hematoma is not the cause for the pain. You kept in your mind, because this is the so much area to expand the hematoma and couldn't pressurize over this vessel, couldn't pressurize over this nerve. But if this patient is have the severe pain, in those cases you have to have the evacuate. Also, you remove the mass. This is very important, and try to look for the other alternative like the plectopraxy or something. So I think better in this case is because the patient is suffering from the pain. This is the one thing you kept in mind related to neuralgic pain rather than, and sometimes it's associated with the lysis and lithosis of the particularly the spine. So I think it maybe give the overcorrections, overtractions associated with the deep pain, osteomyelitis, such kind of the issue associated with the suture or with the tucker. So you remove it, and better you look for the other alternative like the plectopraxy. I think Sujal is do the lot of work related to plectopraxy. He also narrated related to this part.
Absolutely.
Niranjan, this 2 centimeter hematoma in pelvis or in sacral promontory, generally it is painless. It doesn't give any pain.
Yes,
As I rightly said, because it is a loose covering peritoneum over the promontory. Because in obstetrics, we have seen the 10 centimeter hematoma or 8 centimeter hematoma in abdominal wall or in our pelvis, and patient is asymptomatic. But in this case, the pain is there. It may suggest that hematoma may get infected, or a mass can lead to some kind of infection at that places. So here, not only evacuation of the hematoma will be helpful to reduce the pain, but here the culprit is that mass which leads to this all problem. So I think with that hematoma evacuation, that mass is also to be removed to get a permanent cure for the pain. Thank you.
Sir, once you remove the mesh, what about the prolapse? How do you correct the prolapse?
I agree with you, Mahesh.
Sir, if I can interrupt, if you remove the hematoma, well and good, but if you remove also the mesh, then how do you correct the prolapse?
Yeah, it is now already 1 year. 1 year has been passed, so that mesh has become now a tissue. So it doesn't need fixation on that. Perfect. Or as Sanjay told you that you can go for other measures to correct the prolapse if it is at all there. But the mass is because we have seen in our workshop in somewhere where this plastic done, and after 6 months that mass got infected and patient was having severe pain. Then laparotomy done and that mass was to be removed, and along with the mass some other material like with suture material was also to be removed. I do not want to put this case, but it was there.
Can I interrupt, Sanjay? How many months or years later on she faced this problem?
1 year.
Huh?
1 year it is returned.
1 year.
1 year. I think the already fibrosis is happening.
Yes, it becomes tissue.
I think no need of, because the tissue is puckered with so much with this mass.
Yes,
just to remove the mass, and this fibrosis is taken care related to this problem.
Yes. It doesn't require anchoring on any sacrum.
No need of that, because we have the series of cases. We remove the mass and we couldn't do even the plectoplexy or anything, and patient is absolutely, I think, free from the related problem.
Thank you so much, sir. Now your opinion on the second question of Sujal Munshi. This is regarding the rectovaginal plate. Endometriosis.
I think in this case, I think patient is 24. There is no place of any medical management. One thing you write down, because this is adenomyotic tissue. The deep infiltrating endometriosis is absolutely different than the other thing. And the company people is earn the billions of rupees with the placebo treatment like the GnRH or Dynogest. You have to have the radically, surgery is only, today is the gold standard in these cases. This is the 24 years old. This is the fertility enhancing surgery associated with the conservative line of treatment. Many cases, even without any the ovary involvement, patient is presented with the colorectal nodules, bowel involvement, and bladder involvement. So I think it's there is no correlated between the ovarian endometrioma and deep infiltrating endometrium. These two entities absolutely different one. I think if you associate with the endometrioma, better you do the cystectomy. It's reduced the reserve of the ovary. The AMH level is going down, but I think it's considered to be gold standard to excise it to prevent the recurrence. But you deal with the deep infiltrating endometriosis with the surgery. You have to have the excise this one. Otherwise, patient is couldn't relieve from the pain, couldn't enjoy the quality life. Because one of the important part related to DI, deep infiltrating endometriosis, associated with the suicidal tendency. In our history taking in our institute, we find out that even the young patient associated with the severe pain due to the endometriosis, out of 10, 1 to 2 patients have the suicidal tendency. So I think the basic aim, the fertility is the future part, but give the quality life and free from the pain. This is the real motto related to us with the DI. So in this case, bladder nodules is also excised and colorectal nodules is also excised, and to give the good, better quality life. And also we realize that over a period of time, if you remove the DI, it may be associated with the so many chemical and biochemical substance related to pelvis, is altered the chemical milieu of the pelvis. If you remove the deep infiltrating endometriosis, and we realize that the 30 to 40% patient is, I think, carry the natural pregnancy after the surgery in our center.
It is at par with any fertility treatment. A good surgery would carry same pregnancy rate as compared to any advanced fertility surgery. So,
absolutely right, Sujal.
Absolutely right. Great. Wonderful explanation. That's why we have an expert, a renowned, world-renowned expert from Ahmedabad to be with us. Thank you so much. That was wonderful. I hope the audience have got that take-home message. And now we will go to the case 3. And I call upon Dr. Sunil. Dr. Sunil Shah, please, you can go ahead and read your case. I'm presenting to you.
Can you go to the previous slide, please?
Yes.
Yes, okay, fine. 29-year-old married woman complaining of severe dysmenorrhea and dyspareunia. She underwent laparotomy and surgery was abandoned due to frozen pelvis. What is the management?
Yes, sir.
Very unfortunate woman. I would like to investigate her thoroughly. Looking to the history, most likely it is an severe endometriosis grade 3. So I would like to ask her to go for a very good ultrasonography, look for the uterus involvement, look for the rectovaginal involvement, look for the ovarian involvement. And I would also like to investigate her by MRI as well as blood investigation. I would also like to check her for the TB PCR or tuberculosis. Since it's a frozen pelvis, most likely looking to the history, it is an endometriosis case. And then we should proceed for the surgery. And nothing is mentioned about her fertility. So that also we have to look for. Dr. Niranjan.
Yeah, the husband, there is no male factor. She's already got this severe dysmenorrhea, dyspareunia. Unfortunately, this patient had come to me. Actually, they wanted me to transfer her immediately as soon as they opened the abdomen, and it was all stuck up. The bowel, intestines were all stuck up. The Poucher Douglas was obliterated. And I said, now see, you have decided to close. It's no point transferring her to me right now. So you please manage her post-operatively. Let us see what can be done. And then she landed up with me after 6 weeks. Because that time, there were 2 surgeons, means both were gynecologists, very senior. They are all honoraries in a peripheral hospital. You can understand that I am at Sion Hospital, sir. It is at the crossroad of Western Highway and Eastern Express Highway, and we have got about 8 maternity hospitals on one side and 10 hospitals. So it caters to approximately 22 total in Bombay. So that is the reason. So once we investigated that, now what has to be done, sir? Because now she has come to a tertiary center.
So obvious
Would you like to do the
surgery for
laparoscope inside?
surgery.
Sir, I agree with you. You have said that it is MRI to be done. We did an MRI. It showed the same thing.
Yes.
There are the bilateral kissing ovaries. Pouch or Douglas is obliterated. And there is omentum which has been plastered there. Sigmoid colon is adherent to the left ovarian. It's totally, you cannot see even the left ovary. It's totally covered with that sigmoid colon and omentum. The whole anatomy.
I think now we have a good surgeon, laparoscopic surgeon. So ideally, if
Yes.
I could not operate, I should transfer it to you or Sanjay Bhai or Sujal, who are regularly doing such kind of the surgery. But I think this patient should be offered a very good surgery because he has already passed through a pain of a failed laparotomy. So the best laparoscopic surgeon, we have heard there are so many good laparoscopic surgeons and they are doing wonderful surgeries. So ideally they should be offer a laparoscopic surgery and she should be relieved of all this pain.
Yes, Dr. Mahesh Gupta.
Yeah.
After that, Dr. Manish Pandya.
Yeah, here one word about the MRI. Because all the time we are referring the patient for MRI for a pelvic mass. I think the sonography is more sensitive and more specific than the MRI. Because the MRI, most of the time I have seen in my practice that it creates a myth about the mass. And the mass which can be taken care of by gynecologists that are simply referred to the onco surgeons. So MRI many times doesn't give an extra or any added advantage than the sonography. What do you say, Sanjay, about that?
Sir, first Manish Pandya, then I will go to Sanjay Patel, sir.
Thank you, Niranjan sir. If suppose she is fertile or infertile, 29-year-old female with severe dysmenorrhea, dyspareunia, and laparotomy for frozen pelvis, there is a definite laparoscopy, and thanks Sanjay who had taught us how to do the butterfly technique and remove all the endometriosis. I had seen so many frozen pelvis, and if you see above the frozen pelvis, everything was clear. So you just take definitely your story was totally stuck, but you can uncover all this thing by proper instrumentation like harmonic, vessel sealer, and you can and definitely you can relieve her symptom. If she is a case of infertility, we can try to give her maximum advantage by taking care of both ovaries and removing the rectal nodules and removing all the adhesions. If she is a case of fertility, everything is there. We can do very good hysterectomy with bilateral salpingo oophorectomy, and all the peritoneal seedlings and nodules we have to remove, and if required we can give her GnRH afterwards if we think that something is remaining inside. Now words of question from Sanjay Bhai.
Sanjay Bhai, she has got bilateral ovarian masses. She has got Poucher Douglas, which is totally obliterated. Totally obliterated till the fundus. The left ovary is totally not seen. It is covered with sigmoid and the omentum. And the right ovary is also not visualized, sir. And she has been, now there is only laparoscopy which can help her, because repeat laparotomy would not be the option.
I think this is the routine part in our institutes. Accordingly, I believe that there is not considered to be any cases is inoperable except the malignancy. Because benign condition, if you have the patience, you understand the texture of tissue, always you find out the plane of cleavage. One important part, she is only 29. I think one important, who is performed the laparotomy. This experience of the person is related to this part, because majority time what's happened, somebody couldn't know the severity of disease and jump for the laparotomy and realize that, oh, this is stuck everything. and close it and label as inoperable. Majority time cases is so simple. If you put the scope and you realize that, if you do the adhesiolysis, find out the plane, and absolutely pelvis is clear. She is only 29. I think ovary is considered to be endocrine organ because it's very important for the skin, hair, heart, and even the bone. So at the age of 29, we never think and jump, except in some cases. Even though I removed at the age of 26, patient age is 26, I removed everything because the underwent go for the 5 times surgery from the 16 year to the 26. Underwent go for the 5 times surgery for the endometriosis with the one kidney already compromised related to endometriosis. In these cases, you go for the radical approach is fine. But even the previously only one surgery with the somebody is labeled inoperable cases, sometimes such cases is so simple and you give little bit patience toward your surgery. Majority time you find out the good plane of cleavage and give the good life. Also you explain that this endometriosis is bound to be happen recurrence. It's the progressive disease. So it might be in the future you require the another second surgery related to uterus or related to ovary. But at the age of 29, I personally prefer to keep the ovary as much as possible, remove the endometrioma, do the adhesiolysis, do the rectal sieving, remove all the defiltrated nodules and restore the normal anatomy. And majority time patient is enjoying the good quality life. I personally not believe the post-operative GnRH. If you radically remove everything, there is no place of GnRH because it is a particular for the short time. It may be held for the couple of months, for the 4 to 6 months. There is no sense related to give the post-operative GnRH or Dinojost.
Absolutely, sir. This is a case of infertility with bilateral chocolate endometriosis, and it's a totally obliterated pouch of the Douglas. That's what it was, totally frozen. They did a laparoscopic, operative laparoscopy, did total cystectomy, restored the anatomy because we had to see that the fallopian tubes and the ovary are in the now proper anatomical position. How much ever you do, and we have to be very careful as you are dealing with bowel, and that's what Dr. Sanjay Patel has beautifully shown the way, and even Dr. Manish Pandya said that this requires a wonderful technique to be done, and that's what we had to do it. And mind you, sir, God is so kind for such women. The fallopian tubes are patent. I remember Dr. P.K. Shah sir telling, we have operated in 90s like endometriosis every second, third OT every day. I had the privilege of assisting sir in those days. Sir is a very bold surgeon. With his fingers, he used to just make a cleavage and open the planes and literally separate the ovarian from stuck up being at the posterior fossa or the posterior surface of the uterus, evacuate, do a cystectomy, restore the anatomy. And fallopian tubes, when you do a chromoperturbation, sir, they are absolutely normal. They are patent. And I think Dr. P.K. Shah sir can surely highlight his experience of more than 35 to 40 years. That's what sir had told me. Sir, your comments on that?
Yeah, I think with this case, when you have a frozen pelvis, there are only 3 diagnoses. Number 1 is ovarian malignancy. Number 2, chronic infection and especially tuberculosis. And number 3 is endometriosis. Now, if you are in a position, in a place where you cannot operate on a frozen pelvis, at least do biopsy of the omentum, number 1, or any tissue in the pelvis. Take out the washing and send it for histopathology or histology before closing it, because I know it is not everybody's cup of tea.
Absolutely.
To manage frozen pelvis. Niranjan knows very well that we used to have so many cases of frozen pelvis sent to us at Sion Hospital because it was a tertiary hospital. But we used to get into the plane and somehow manage. So you have to find out, you must know the anatomy well, especially of the deep pelvis. And you must be bold enough, like Sanjay, to separate the adhesions without worrying. But there are surgeons, there are oncosurgeons who will help you out. But you can't keep closing such abdomen. Where she will go? So I think you have to be very bold and keep these 3 things in mind. chronic infection, malignancy, and endometriosis. And we have seen beautiful operations by Dr. Sanjay and other endoscopic surgeons for deep infiltrating endometriosis and even frozen pelvis. You have to start somewhere. You will definitely get something. Thank you.
Absolutely, sir. Those pearls of wisdom were very importantly said. Such situations can come across to any gynecologist, professional career, medico-legally. Dr. MC Patel has already said that you are supposed to have a proper consent, operate her properly. But in such situations, Dr. PK Shah, I would like to summarize, sir, that you need to take a biopsy, you need to give a proper peritoneal wash, explain the relatives, see that not to panic and calm them down, and see that you need to have a good endoscopic surgeon or a senior person in such cases. Sir, last question with this case, Dr. Sanjay Patel, sir, I want to ask you, then I will move on to the next. Do you do a ureteric catheterization in such cases when you are, sir, you can do without a ureteric catheterization. You're something different, but we have got, endoscopy is to be done by a gynecologist. So what would you advise, sir, to our users, the delegates who have joined today?
Accordingly, me the ureteric catheter give the benefit to the us for the surgery. It's give the create the more problem if you do the ureteric catheter, because one thing with this one is, with the ureteric catheter, you lost the mobility of the ureter. Then your dissection is create the much more complicated, and sometimes you encounter the injury of the ureter during the time of ureterolysis. So I think the best part, you perform the surgery, you do the proper ureterolysis. If any doubt, if you feel that there is a thermal injury of the ureter or maybe any surgical trauma over this ureter, better you later on you put the J stent. We started with this fiber optic ureter invented by the Karstow's company in 2003. And the fiber illuminates pathway of this ureter to find out the pathway of the ureter. But we realized that I think due to this rigid attitude of this fiber optic ureteric catheter, it creates a lot of problem. And after 2005 onward, we stopped this one is doing the stenting of the ureter in the cases of the endometriosis or any malignant surgery. And we realized that I think we get the mobility, we get the elasticity of the tissue, so we properly mobilize the ureter properly, and it's much more helpful without any ureteric catheter rather than we be keeping the catheter.
Sir, it was such a wonderful explanation. We started with Dr. Sunil Shah, explained so nicely, and the pearls of wisdom by Dr. Sanjay Patel, Manish Pandya, and PK Shah, sir. It was excellent management which you have showed, and the path how to go about to deal in such cases. Thank you so much. I would request now to go ahead with case number 4. Yes, please. Dr. Sejal Naik.
Yes, sir. Yeah.
Please go ahead. Please go ahead. Thank you.
Yeah. Thank you so much, sir. She is a case of 34-year-old married woman with AMH of 1.8. Came to the clinic with complaint of infertility. Ultrasound showed 4 centimeter endometrioma. She has undergone 3 IUI cycles which failed. Wishes to conceive. All other hormonal tests were normal. Husband semen analysis showed mild oligospermia. So how would you manage the patient? Viewing her age, 34 years, at the edge of reducing future fertility, with a borderline AMH low, and she has 4 centimeter endometrioma, but she still has no pain symptoms, as if it is not mentioned here, and with cofactor of infertility with mild oligospermia. So being a laparoscopic surgeon, I attempt to operate such a virgin abdomen, but considering her age, the best result I can give her with IVF. So without wasting much more time, what I would do in this such case, endometrioma is not that big. And if the accessibility to ovary is good enough by ultrasound and the endometrioma doesn't hamper between my pickup, so I would straightforward ask her to undergo ART cycle first, and then as soon as that is the best result she can get faster and faster too. So as per the ASRM and European Society's latest guidelines and suggestions, that due to the surgery that also causes the reduced ovarian reserve, and even doses for gonadotropins for stimulation of such as operated ovaries, the requirement is more. So I would do it for IVF for the lady.
Yes, Manish sir.
Stejalben, would you like to aspirate this endometrioma before putting her for ovulation induction or starting gonadotropin?
No, not at all. I will never do aspiration. Rather, I will first check whether the endometrioma is not in between my pickup and like the normal ovarian tissue. So I know there is a risk of contamination of the follicles with the endometriotic fluid, abscess formation of these endometrioma. But if it is accessible nicely, because surgery itself will delay her procedure of IVF. And
no, I am just talking about the aspirating to the vagina before starting your.
No aspiration before or after or during pickup. No.
So there is a no-touch technique. Don't touch the endometrioma, which is less than 5 centimeter in an old lady with low AMH and wants to have fertility. So just ignore that endometrioma if it is less than 5 centimeter. That should be the message.
Yes, for her, yeah. Actually, it should be an individually based management here. But the best thing what I feel is for her is the straightforward IVF.
Okay.
Well, thank you. Dr. Sanjay Patel sir, your opinion on that. Mahesh Gupta sir. Sir, I want to know the view of endoscopist. Dr. Sujal Munshi, endoscopist. તમારે પાસે આ પેશન્ટ આવીને અલ્ટ્રાસાઉન્ડ મારો ઓપરેશન કરો સર, મને બચ્ચા જોઈએ છે.
Niranjan, no endoscopic surgeon would like to leave this patient without surgery.
Without
surgery.
Sir, it is matter of fact that whether the patient first ends up with an IVF specialist or an endoscopic surgeon. I would very frankly tell here that
we are both, so we have to give justification to the patient.
So I've been working with an IVF center for past 16 years now, very carefully, and I've seen the complete change in the spectrum. In my initial years, 2008, 2010, any endometriosis correction, then only proceed for IVF. That was the dictum. Past 5 to 10 years, more and more studies are coming that if patient has issues with ovarian reserve, patient is asymptomatic and fertility is the only issue, address the fertility first. There are centers which do pooling of the embryos, and for better pregnancy outcome, they may freeze the embryos, do corrective surgery, and then go ahead with the transfer. That is also one of the techniques if patient has symptomatic issues also. We as endoscopic surgeons have seen complications when endometriomas and endometriosis are left inside and pickups are being done. So whenever a significant size of endometriosis or endometrioma is there inside, sometimes looking at the symptoms, we still prefer to do a procedure, because if patient ends up in ovarian abscess by any means during the pickup or during this thing, then she may end up losing a ovary and a definitive grade surgery. So Dr. Sejal very rightly said that location of endometrioma is equally important. If you have access to good amount of follicles, antral follicles, which are likely to grow as follicles during the pickup, then you can still go away and do an IVF before this. Second is the ongoing pregnancy with endometriosis inside is completely different from a normal pelvis. So that also should be counseled to the patient, that if you are leaving disease inside and she is going ahead with the pregnancy, not only pregnancy, her final delivery, her C-section, everything is going to be different. So in all these conditions, a very balanced judgment is required. Assess in terms of symptoms. If you are leaving the disease inside, all the pros and cons should be discussed with the patient before going ahead with the IVF. So that still is to be done, even though a lot of studies are coming that you can straight away go for IVF, but it has also got limited disadvantages. So it should be counseled to the patient.
But Susan, the question is still remain. What will you do?
So if patient is symptomatic, okay.
No, in this case, what the Sejal mentioned.
No, see, if IVF is possible, I would still go ahead with IVF.
Just
because
brief.
still go ahead with IVF.
Sir, we have crossed more than 2 hours and 40 minutes. We have crossed 2 hours and 40 minutes. 850 users are there. They are still stuck up, but we have limited time. Kindly be brief and just come to the point. Dr. Sejal Naik has said that she would like to go for IVF. Manish Pandya sir said that would you like to put a needle and puncture and then go? No. Sujal Munshi has said that now the things have changed and he would like to go for IVF, though he's an endoscopist. And
practically speaking, in our country, the IVF cost is too much than the surgical cost.
Yes. So what do you want to say?
And in Western countries, the scenario is different.
Okay.
So if you will not get a result after IVF, then you will go for surgery.
Hello,
okay, Dr. Manish Pandya, Dr. Sejal Naik, and then we go to the last question.
Mahesh,
yes.
The age of this patient, AMI, and she has undergone 3 IUI cycles. So see that in this 3 IUI cycle, they might have undergone ovulation induction. So there is a good follicular cohort was there. Then they had tried IUI. Second, this patient was shown endometrioma on no dyspareunia on any. There is no endometriosis is the complaint of this patient.
Yes.
This patient complaint is of infertility and she wants to conceive. So let's give her the best which is available. As Sujal has rightly said,
Okay, I think Sejal, your last take-home message. सब घूम फिर के यहाँ आपके पास ही आए हैं.
So if it is the financial constraint, then I would rather very much sure about offering her IVF first, because then it will give her the best result, possible result to her, and that to be sooner. Rather than surgery, it will delay the procedure, it will add on cost, because doing surgery will not give her a pregnancy. So if possibly it is possible to do IVF before surgery, without surgery, that is for especially for the poor patient, they should straightforward, without wasting money here and there, should go with IVF.
Because her husband has got oligospermia also.
Manish, can I do any comment?
Yes, sir. Last comment.
Yes, Dada, always.
I think before 20
Shashwat Jani is waiting.
Before 20 years back, we, I think, start with the aspiration of the endometrioma. But I think we do in the couple of cases, we not satisfied that, because it's sometimes thick, sometimes the stony particle remain inside the endometrioma and it may be created
nothing.
So I think the aspiration is not the right approach, and now no one can do it. Second important part related to out of 100 cases of the endometrioma with the ovum pickup you go for, every weekly we get the one patient with the endometriosis with the ovarian abscess. So I think there is a higher chance, whatever we take care, there is some chances of, because you are taking out all the follicles through the vagina. So you piercing the vagina, there is some bacteria is enter inside the ovary, and whatever you take care, whatever you give the antibiotic, some of the patient, I think it's the number of cases is very less, but 5% cases with suspecting as endometriosis with the ovarian, with the stimulation of the ovary, and we go for the ovum pickup, it's end up with the ovarian abscess. Third important part, this patient is asymptomatic. 30% patient is without pain. Even though in the frozen pelvis of the endometriosis, 30% patient is without pain. The endometriosis may be alter the chemical milieu of the pelvis. and it also altered the tubo-ovarian relationship. In such kind of the cases, because the 1.8 is the not less, there is a two colony. One school of thought is the ART, those who do the hardcore ART. One of the school of thought related to endoscopy. But I try to make the balance it with my experiences, because we have to do the very large series. Even the patient is underwent go for the multiple time IVF failure. In such kind of the cases, you go for the surgery, you restore, because endometriosis altered the tubo-ovarian relationship. You correct the tubo-ovarian relationship, you remove all the fibrotic cyst wall of the ovary. Whatever you leave the ovarian tissue left behind, respond well. अपने दिमाग में से टेंशन निकाल दो, you are free. This is endometrioma, just like the tension. You remove the tensions and whatever you correct it. जैसे बारिश आती है और पैदे खुलने लगते हैं, it looks the green. The same way, you remove the pathology, automatically there is a ciliary current between tubes and ovary, and 30 to 40% patient is carry the natural pregnancy with the 1.8 AMH at the age of 34. I tell you. Second important part, if you restore the anatomy and you leave the whatever the healthy ovarian tissue respond well with the hormones, because the fibrotic ovary couldn't respond with the hormones, you require the more hormonal injections, particularly whenever you deal with the endometrioma with the ovarian stimulation. If you remove the endometrioma, remove the fibrotic portion, and it little bit compromise the over AMH level, but it responds well with the low dose of the hormones. And I think your fertility outcome is also better with the IVF. And there is one of the important part related to burst endometrioma. Once the pregnancies go, and sometimes if you leave the such kind of the endometrioma, it may be burst. It's the leakage of the endometrioma happen, and patient is presented with the severe pain. So three things you kept in mind related to abscess. There is no sense of the ovarian pickup. There is a surgery definitely give the wonderful outcome related to this part. Because it restored the tubo-ovarian relations, less stimulations, hormones is required, and fifth is related to rupture endometrioma during the time of pregnancy.
So I think in short, we should go ahead with IVF for endoscopy, sir.
Endoscopy.
Endoscopy.
So you guys have heard the different perspective. That's why we have got an IVF consultant. We have an endoscopic surgeon, but the case has to be individualized. And accordingly, you have to see the actual contribution, the monetary contribution which the patient can give, and do ethical practice. That is most important. And what sir has said, that don't just put a needle inside to aspirate that endometrioma, that includes and causes infection. And please individualize your case and accordingly treat it. Depending upon all these factors, you can go ahead with an IVF or endoscopy. I leave it there. We go to Dr. Manish Pandya, sir. Please go ahead.
Hello.
Yes, sir.
Give me the case. Okay. A 29-year-old infertile patient married since 2 years presented with intense pain in hypogastric region and left iliac fossa for 7 days. Okay. If you see the history, is the study of past in light of presence to have good future. Chronic pelvic pain related to menstrual period for 1 year, and it is worsening since last 4 months. So if we see the history, she has complained of since 7 days, progression of disease increasing since last 4 months, and 1 year she has got complaint. 28-year-old, so she probably from the Mumbai, because at the 28 years she got married at 26 year of age, and now she wants fertility. If you see the physical examination, vitals are normal, no fever, flat abdomen, presence of bowel sound is good. So there is no question of bowel involvement. Pain at the palpation of hypogastrium, so per abdomen pain is there in left iliac fossa, and absence of peritoneal sign. Good. If we do per vaginal examination, there is a sir, please keep it. Retroverted uterus, fibroblastic colon, intense pain at the uterine mobilization at the palpation of posterior and left lateral cul-de-sac. So it is a deep palpation perineum. You can feel the mass. It is 5/6, separate from uterus, so no uterine origin. It is of ovarian origin. Ultrasound says 5/6 centimeter cyst, freeze, because some pre-fluid is there. So that was the cause of pain. Now next, sir. What will be my diagnosis? It is a chocolate cyst. Management approach, definitely laparoscopy, gold standard laparoscopy, no role of Dinoges, GnRH, progesterone. I will do laparoscopic management of this patient, and believe me, as such case is looking simple, but whenever you are operating on any endometriosis case, so many times the looking simple case become very difficult, and very difficult looking case become very clear or very not difficult. So prepare always all laparoscopic surgery in your mind that you are dealing with a Pandora's box. So prepare with all the facilities like vasopressin, harmonic, ligature, everything should be there. Okay, sir, you are giving me video also. Thank you. So this is a clear cut left chocolate cyst. We had lifted from the pelvic fossa. You can see it is stuck, and this is the common thing from which it should burst. Okay, so there is a typical chocolate cyst. We had removed with the cold scissor, doing suction with the suction cannula. So there is little bit spillage. Now washing. So all solution of pollution is dilution according to the Tillind, and we can see there is a typical endometriotic chocolate cyst. We should remove the cyst wall as much as possible by just stripping it. Yes, sir. Thank you, Dr. Niranjan, for giving me beautiful case with this explanation. Only the hardest instrument on your trolley is your suction cannula. So use suction cannula judiciously, and this is a very good Clemoferran curved scissor. So you can cut it whenever it is necessary. And once you are in a very good plane, you can remove the tissue beautifully. And at this patient is of infertility, try to save the ovary as much as possible for future fertility. So yeah, this is a very good case. We are the person who is doing is beautiful dissection, and they are removing and stripping the ovary. And this is the only thing that we have to make the ovary naked of this endometriotic patches, and that is the best option we can give to our patients. Again, we are doing with suction cannula. This is the hardest instrument, so you can have a very good cleavage. So remove the clip, and now I think they are using some laser shots. Yes, fantastic. The institute has got CO2 laser. The laser shots are there for removing or stripping of the ovary. Thank you, sir. And with the laser shot, there is always fume. So suction cannula is not only doing the suction, but it also removes the nascent fume of carbon dioxide laser or whatsoever laser they are using. So stripping of the ovary, and by using the laser, you are preventing the antral follicle little bit more compared to bipolar coagulation. So it is a good endometriosis looks pale yellow, and all the reddish tissue belongs to ovary. So they are doing the dissection at the right plane. Yes, sir. Fantastic. Small shots of laser are there, and suction is also suctioning the fumes. Yes. Now thing is over, and we are clearing the ovary, or we are cleaning the ovary, and all the endometriotic patch inside the ovarian tissue are getting burned with. Yes, very good. Now this is a bipolar with bipolar coagulation of the small vessels, or to have a hemostasis. Sorry. Now the next question is whether we should suture this ovary or not. Previously we are suturing, nowadays we are not suturing this ovary. So gold standard is operative laparoscopy, nothing else. And then from next month onwards starts your infertility treatment or ovulation inducing drugs, and you will get the beautiful result, because you can see the tubo-ovarian relationship is good, and only thing is only chocolate cyst, and surgery is the gold standard. Here I differ from the previous case, because this is 28-year age, chocolate cyst, dyspareunia, and endometriosis causing the infertility, and she wants to conceive. The surgery is the only answer. Thank you, Niranjan sir.
Thank you. Wonderful surgery being shown. That was CO2 laser. That's what I wanted to show. And obviously you can use an ablative procedure. I want to ask one question to you, whether ablative procedure has to be done or cystectomy would be the option.
Sir, if you have got facility of CO2 laser like in your institute, it is good. But if it is not there, then simple stripping of this endometric lesion and fulgurate whenever you are watching the endometric spot by bipolar, not the black chalky black tissue. but just fulgurate that it should not recur. That also be the good option.
So that's what I wanted to show you endoscopy for all, endoscopy for every gynecologist.
Yes, sir.
99% don't have CO2 laser, and that's what I wanted to show, that what we need to have an armamentarium where simple cautery, monopolar or bipolar cautery only can also work. And at the same time, we have to see that the ovarian reserve is not compromised and our AMH level is quite good. Dr. Sanjay Patel, would you like to comment on this? Anything else? Be brief, and then we go for Dr. Shashwat Jani's case.
I think, Dr. Niranjan, there is no need of any laser in these cases.
Yes.
The stripping of the ovary and use the judicious bipolar with the under continuous irrigation is absolutely fine one. Okay.
Thank you. Wonderful. That was the answer. Sujal, I think you agree with Dr. Manish and Sanjay.
Sanjay bhai, I agree with Sanjay bhai.
Yes, we all agree. Now we go to the next case. Thank you so much, all of you. Wonderful. We have got Dr. Shashwat Jani with us, and he's going to read his case.
Good evening, sir.
Good evening.
And good evening to all legendary laparoscopic surgeons.
Good evening, Shashwat.
My case is, good evening, sir. 22-year-old unmarried girl complaining of severe dysmenorrhea. She has consulted many physicians and her MRI shows bilateral endometriomas of 5 centimeter. And uterus shows severe, uterus shows an adenomyoma of 4 by 5 centimeter. So how would you manage this patient? First of all, counseling is very, very important in these types of cases where patient. Hello.
Yeah, we can hear.
Yes, you are audible.
Yes, counseling is very, very important regarding case of complaint of dysmenorrhea and future fertility point of view, because she is unmarried and she is likely a couple of years or so that's why counseling is very important. Then we can offer her, if she is planning to get married within 1 or 2 years, so we can delay her surgery and medical management also. And if it fails, then we can go for the laparoscopic surgery.
Yes, sir. Anybody wants to have a difference of opinion here? Dr. Manish, Dr. Sujal. Yes.
Yes, sir.
She is unmarried, sir. Sir, she is unmarried.
But
she is
severe
unmarried. If you do an incomplete surgery, unfortunately, she will come with recurrence.
She might require another surgery.
So Shashwat has rightly said that counseling is utmost important. Number 1. Number 2, she has got severe dysmenorrhea. Both ovary has got 5 centimeter endometrioma and adenoma of 4 to 5 centimeter. So she had came to you for relieving of this pain. And believe me, no medicine, no diagnosis, nothing will help to relieve the pain. So we have to give.
Yes, we can offer her surgical option.
With the counseling, counseling that she may require next surgery. To see, he has got patient that she had came for 6 times of surgery. But if you do her good surgery, she will be of relief of pain and with good adenoma resection and endometriosis cyst resection, we can give her a good quality life, and post marital life is also good, because with this cyst, if she got married, there is always dyspareunia and she cannot enjoy the fruit of marriage. Or
yes, sir. But we have to counsel her about future fertility problem also. If we are removing bilateral endometrioma,
so we have to do fertility preserving surgery. Fertility preserving surgery with adenoma resection. With if we are not able to do, give it to the Sanjay. That Sanjay will do this surgery, and Sanjay will agree with me that with this pain, she has to go for surgery. Am I right, Sanjay?
Yes.
I want to add one thing. Adenomyomectomy will be very harmful. Basically, the fertility problem will be there, but once she conceives also,
Then adenomyoma, because of adenomyomectomy, there is a chances of rupture of the uterus. I think I
So we
would
have
like
to
to know
counsel
the
Sunil.
opinion of the Dr. Sanjay Bhai, because she's so young, 22 year, and going for such a radical surgery straight away without medical trial is not good. Sanjay Bhai, your opinion?
Sanjay Bhai will tell endoscopy only, nothing else.
Sir is master of adenomyomectomy. We know, so he can do better than us.
And Sanjay has taught us how to
I
do
agree
adenoma
with,
resection.
I agree. I don't have any doubt about Sanjay Bhai's surgery. I know him. He's one of the finest surgeon in the world. I have seen him operating many times. I went to his hospital at Mehsana also to see his surgery. But about adenomyomectomy, I would like to know about his opinion and about the future fertility and chances of rupture of the uterus.
Now Sanjay is ball in your court.
Actually, Manish and Dr. Sunil, one thing I tell you, she is only 22. I think for the endometriosis, it's not the matter related to age. One of the important part related to the pain-free and quality.
Pain.
But I think one important part you counsel related to patient and patient relative. After surgery, as soon as possible, you try to make them married. Because the final call is the once you carry the pregnancy, then you relieve from the pain. Second important part, I think we have the largest series in world related to adenoma resections. We innovated the different technique of the hood technique, slice technique, and even the elliptical strip manner technique. Don't go for the beyond 50% of the adenomyotic tissue, remove it. Not cross the limit of the 50% adenomyotic tissue. I think I tell you the one of the fact, if you remove the 30 or 40% adenomyotic tissue, I think the next day patient is relieved from the dysmenorrhea and menorrhagia. Because I think adenomyotic is always with the tensions. What it's maybe associated with the so many lacunae collection in the posterior. Basically, it's more involved on the posterior endometriosis with the posterior wall of the uterus. If the congenital adenomyosis may be developed on the right or left corner of the uterus, it's a different story. Acum we not discuss related to this part. But in this case, endometrioma associated with the posterior surface of the uterus is involved with the adenomyosis. In these cases, if the serosa is involved, I think you go for the elliptical strip manner, remove the 40%. And another case is if the serosa is not involved, in those cases you go for the hood technique. Dr. Prakash Trivedi already show you how you create the hood and you stitch it properly. Believe me, we crossed the 738 cases of the adenoma resections. Only the 2 patients is presented with the rupture uterus.
Yes.
2 patients. Because at that time we are also premature and we resected the more adenomyotic tissue. We opened the cavity. Both the cases associated with the rupture uterus presented with we open the cavity and we suture it. I think one of the important part, the mapping of the particular this case is very important. You try to make the posterior wall preserve at minimum 2.5 centimeter. So you are away from the endometrium to the myometrium, maintain the 2.5 centimeter, and rest of the bulge adenoma you remove it. So integrity of the uterus you try to make the uterus. Once you open the cavity, there is ample of chances of the Esserman and ample of chances of the rupture uterus. We have the 7 or 8 cases of the scar dehiscence. But I think majority time the rectum is stuck with this one and it's guard the pregnancy. I think, can you understand what I am telling Sujal, yes, Manish or Niranjan?
Yes, sir. Yes,
sir. Wonderful. Because I think Dr. Mahesh is also very experienced related to this part. Because we do on the posterior surface, thus we find out the scar dehiscence, but it's guard with the rectum with the adhesions. And that's why I think the rupture uterus rate is very less in our. We previously we squared and upgrade related to adenoma after the adenoma surgery, and we deliver at the 30 to 34 weeks maybe, and we told that there is a higher chances of. But gradually we stretch ourselves with the experience, because this work we started in from the 1997. This is also one of the story I tell you how I invented the adenoma resection. Because what's happened previously, I put the incision and I realized that this is rather than the fibroid, this is adenoma. It couldn't pop out adenomyosis, and we suture it and we come back. Very my close relative underwent for the glioma of the surgery, and Dr. Mishra at the Hinduja hospital he operated for the glioma surgery, And he told that, Sanjay, this is very near to the vital structure. Just we remove the 40% of the glioma, because basic our aim to relieve the tensions in the brain. And if we create the vacuum and we create the space, I think this patient is absolutely fine. And even though maintain all the physical activity related to motor, sensory tone, and even though near to the speech center, also we preserve the space. The next day we apply this one. And it's a very simple way. Judiciously, you do the mapping of this case, and only 40 to 50% adenomyotic tissue remove. You give the very good quality life. In those cases, the adenoma is bigger. Whole localized adenoma associated with the adenomyosis of the posterior surface of the uterus. In those cases, I think there is a chances of the recurrence within 3 years. But if the localized adenoma, there is a less chances of the recurrence of the particular adenomyosis, and give the better quality life, better fertility life. But the most important part, to motivate the parents and motivate the patient to, as soon as possible, marry and carry the pregnancy. This is the take-home message for the day.
Wonderful, sir.
Thank you, Sanjay. Thank you.
Very good.
It was good.
Very good, Sanjay bhai. Thank you very much.
Thank you, all of you. Thank you so much. Wonderful
Yes, sir.
presentation. I got many congratulatory messages for all of you. They have come from all of
But
India.
you will still receive within for next 48 hours.
Niranjan, I think Saswat is my son PG teacher.
Yes.
Saswat Jani.
Arre, sir, please.
And I think what he created and what he developed the speech, it's unimagined for me. What today I speak related to Dr. PK sir, the same sentence I tell for the Saswat, because he take the so much care. And I think whatever he learned from the, I think, BS hospital, from the Saswat, Akshat and Dr. Babu Bhai, he reached up to the different height, what I feel that today. And I am extremely happy.
Thank you so much, sir.
Jani is the teacher of my son.
Thank you so much, sir.
Congratulations, Shashwat and Sanjay, for making a very good paper. It will come in next journal.
Yes, sir.
That is a
Thank you for the approval.
Thank you. Always welcome. And I always tell everybody that put your paper that world can see that how we Indians are progressing in our paper presentation and in our academic achievement.
Manish, why I salute and respect to the Saswat, because what I am do the lot of work, but I couldn't compel my work. I couldn't publish my work.
That is the Sanjay my complaint to you every time. That जंगल में मोर नाचा किसने देखा जंगल में मोर नाचा.
And speech is learned from the Saswat to compelling the things, and then he started related to adenoma, related to butterfly technique, related to this point, how you preserving the. So he started with the so many, even though within if the speeches get the such a huge enthusiasm, might be we published the so many paper and so many publications we done in the couple of years. Because now he is so much fascinated. He learned from the Saswat, Akshay and Baubai to publish your work related to this part.
Thank you so much,
Niranjan, one compliment,
panelist.
Yes,
we have crossed 3 hours.
Niranjan, one compliment to Dr. PK Shah. Now Dr. PK Shah is looking more Rajasthani than the Gujarati.
Yes, Maharashtrian Bapu.
More like a
Maharastrians, Gujaratis and Rajasthani.
बुड्ढा होगा तेरा बाप.
Bapu.
Yeah.
Sir, we have crossed more than 1,000 viewers.
Wow.
And users have come, and we have even broken all the records. We started at 6 o'clock sharp. It's 9:08 and it's Sunday evening. And I know you have given your most valuable time. Sunday evening is to be spent with your family. But
So this is our extended family.
Yes.
And Niranjan, we will wish that you will be elected as a treasurer IAG, and we will see your installation as a treasurer. All the best for your election.
Thank you, sir. Sir, I wish everyone happy weekend, Sunday night. Have a great week. Be safe, stay strong. Corona is rising, and everyone do your best, however best, of safe distancing and social distancing. Wear your N95 mask. And sir, I want to see all of you very soon. I am very eager. Dr. P.K. Shah sir, Sanjay Patel, Mahesh Gupta, Manish Pandya, Sujal Munshi, Shashwat Jani, and Sunil Shah, and all the
Sejal.
office bearers. I would like to thank Sogog, Minakshi Ben, and Hemant Bhai, Dipesh Dholakia sir, MC Patel, and Maharashtra chapter's chairperson Dr. Prakash Patil to be a part of this webinar. We have crossed boundaries, we have crossed international boundaries today, and I would thank each one of you to be a part of this wonderful webinar. May this friendship of associations continue together for more webinars to come in the future. This is just the beginning, and I wish all of you a wonderful success, and thank you so much. I would like to thank Science Integra, Subbu, Session, Sana, Minal to do the backup, and the host Gaurav to do this webcasting to this 1000 users members. The video recording will be available after 2 days on the YouTube channel Science Integra. Thank you so much, all of you.
Thank you.
Thank you.
Thank you. Good
Thank
night.
you. Good night.
Bye bye. Good
Bye.
night.
Thank you, everybody.